السلام الملكي.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، الرحمن الرحيم، مالك يوم الدين، إياك نعبد وإياك نستعين، اهدنا الصراط المستقيم، صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Good morning, ladies and gentlemen, and welcome to our event dedicated to the advancing our understanding of idiopathic pulmonary fibrosis, IPF. I would like to highlight that this event is a collaboration between the Ministry of Health and the Saudi Society of Clinical Pharmacy. IPF is a progressive and often debilitating lung disease that affects thousands of individuals worldwide, including those here in Saudi Arabia. We are thrilled to convene a distinguished panel of experts who are the front of research, clinical practice, and management strategies for IPF. Today, we aim to explore the multifaceted burden of IPF, not only globally, but also within our region. The discussion will include the latest guidelines for diagnosis and treatment, groundbreaking advancement in IPF management, and the broader implication of patients and healthcare systems. As we dive into the critical dialogue, we invite to engage in thoughtful discussion about the challenges we face, the state of the current research, and how can we collectively work toward a better patient's outcomes in the context of IPF. Together, we can enhance awareness, foster collaboration, and drive forward innovative solutions in the management of the condition. Lastly, I would like to thank our leaders that help pushing innovation. Prof. Al-Judair, our Deputy Assistant of Therapeutic Affairs, Dr. Abdullah Asiri, and Dr. Eid Al-Tairi, our thoughtful medical leads, and our partners, BI, and our amazing organizers, Riyadh Home. Thank you for joining us in this important conversation about idiopathic pulmonary fibrosis. We look forward to an engaging event that inspires us all to take action for those affected by this challenging condition. Without further ado, please welcome with me our first speaker, Prof. Al-Judair. He will be talking about the economic burden and prevalence of IPF worldwide. Prof. Al-Judair is our founding president of Saudi Society of Clinical Pharmacy. He is the Deputy Assistant Minister of Therapeutic Affairs, Ministry of Health. Please welcome Prof. Al-Judair.
Great, thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. وأسعد الله صباحكم جميعا بكل خير. Good morning, everybody, and thank you for being here in this first activity on IPF conducted in collaboration between the Ministry of Health and the Saudi Society of Clinical Pharmacy. I would like to thank all of our speakers. Let me start my talk by showing you the conflict of interest disclosure. I don't have anything to disclose regarding this presentation, and I will not be discussing any off-label use of medications. So I'm not an expert in IPF whatsoever. However, I understand very much the burden of diseases. It's very important to understand that this is a chronic progressive lung disease that affects the interstitial tissues of the lungs, leading to difficulty breathing, affecting the lung function, affecting the quality of life, and causing actually ultimately lots of comorbidities and complications leading to death. So if we talk about the risk factors, as per its name, it's idiopathic, so there are multiple actually risk factors that can contribute to the development of IPF, including smoking, age. It's actually an adulthood disease, more of an older adults disease. Family history, genetics, specific genes, environmental exposure, as well as comorbid conditions such as GERD, sleep apnea, and pulmonary hypertension. Now, the symptoms of IPF range, and I'm sure you're going to discuss this in the remaining part of the meeting today. It starts in early stages as no symptoms or some persistent bothersome cough, but it can actually progress to increasing breathlessness during exercise or daily activities, moving to fatigue and ultimately depression and anxiety. The diagnosis of IPF needs actually a specialist, so that's very important. We're going to talk about this in a few minutes. It's very important to refer patients as soon as possible to a specialist who can actually conduct the required diagnostic investigations and diagnose this patient, as one of the main important issues we have here in Saudi Arabia as well as in the rest of the world is the delayed referral and delayed diagnosis. So high-resolution CT, pulmonary function test, blood test, and lung biopsy sometimes is necessary to confirm the diagnosis. Now, the treatment, until about 10, 12 years ago, we didn't really have much in terms of treatment. The first approval was in 2014 for the anti-fibrotic medications, pirfenidone, followed by nintedanib, and then, of course, supplemental oxygenation and pulmonary rehab. Now, in terms of the disease burden, it's very important to understand that this is a rare condition defined as 1 in 2,000 almost globally, and varying between different geographic regions. So we have around 100,000 patients in the United States who have IPF. Now, if you look at this map, you will see that depending on the region where you live, there are certain regions with a very high IPF prevalence and some with low. And we happen to be in the lower region. This is one of the actually very few diseases that we don't have high incidence of due to multiple things, genetics, environmental aspects, and others. But if you look at the worldwide burden of the disease, looking at the interstitial lung diseases in general, in both sexes, it can affect both sexes, but mainly males. About 70% of them are males. And it affects actually the quality of life significantly. If you look at the IPF as part of the interstitial lung diseases subtypes, it doesn't have a high frequency in Saudi Arabia compared to other countries. In Saudi Arabia, we have about 1 in 2,000 patients based on a publication that was published looking at the prevalence of IPF between 2000 and 2012, where we had about 134 IPF patients were identified. Sure, now we have more, so it's very important also to be able to capture the prevalence as well as the incidence of the disease in Saudi Arabia and in the region these days. Now, one of the also differences is that from that publication is that the survival rate in Saudi Arabia was actually higher than the average survival, average life expectancy after the diagnosis. So globally, we have about 3.5 to 5 years, accounting for about 4 to 4.5 years average after the diagnosis. In Saudi Arabia, we have actually up to 7.6 years in those IPF patients. Now, the cost of the disease varies across different patient population and across different geographical locations, and depending on the level of care that has been given to those patients in different healthcare systems. So the disease cost is not only related to the direct medical cost, but also to the indirect medical costs affecting societal, economic, loss of working days and absenteeism from work, as well as importance in terms of the direct medical costs, which could include hospitalization, inpatient, outpatient visits, medications, which contribute to a significant portion of the economic burden of the disease nowadays. Oxygen supplementation, home health care, and absenteeism, as we mentioned, as you can see, the fractionation of the overall economic impact. Now, these are different studies looking at the different countries, states, evaluating the inpatient, outpatient, and medications impact in terms of the cost of the overall healthcare provided to those patients. And it showed that inpatient comes as first in terms of once the patient requires hospitalization, then inpatient care comes as first in terms of the overall healthcare costs, followed by medications and then outpatient care. Now, this is an example of Australia, for example, versus Spain, where they looked at the different fractionation of the economic burden. And in Australia, where they utilize antifibrotic medications widely in those patients, evaluated the economic impact in terms of medical and non-medical cost, showed that up to 60% of the cost is coming actually from medications. If you look at Spain, for example, the direct medical cost was about $30,000 in Spain. We are not far away from this in Saudi Arabia in terms of medications, at least. We still do not have an official economic burden of PIF in Saudi Arabia, which I think is very important to quantify if we are going to evaluate the use of antifibrotic agents. And I'm not talking about the only 2 approved medications for IPF nowadays. I'm talking about what's coming in the pipeline. So we are actually embarking on an economic burden, societal and economic burden study of IPF in Saudi Arabia, and I'm calling for everyone who's interested to be part of this, looking at the overall healthcare costs, hospitalization and resource utilization, the quality of life and the economic impact, as well as the comparative cost of different modalities of management, inpatient versus outpatient, medications included, the absenteeism and loss of working days, and so on. So I'm not going to talk about the IPF management because I know we're going to have deep dive when it comes to this. This is a quick diagnostic algorithm for IPF. I put it there just to highlight one very important message. The diagnosis of IPF needs pulmonologists who are trained in IPF, who can actually identify those patients who are at higher risk of IPF and confirm the diagnosis. However, without appropriate and timely referral of those patients, delays in diagnosis can happen and will happen. One of the very important thing is educating other physicians in different areas of practice, such as family medicine physicians, of early identification and early referral, evaluating the family history and potentially refer those patients to a specialist to confirm the diagnosis. Now, one of the things that we really have, that we really need to work on in Saudi Arabia is to validate the family history and genetics in diagnostics in Saudi Arabia, which we have no studies so far. The guidelines in terms of management stress on very important aspect, which is integrating the patient preference and also the multidisciplinary care of different healthcare professionals, including physical therapists, respiratory therapists, nurses, pharmacists, and others in the multidisciplinary care of those patients, as it is really important to provide a holistic approach of care when it comes to those patients. Now, we are expecting hopefully some other new agents. Some of them you could recognize here in the slide, and they vary from totally new molecules to other agents that have been tested in different indications, as you can see, to a Me Too drug, okay? So for example, we have the first one, the pamrevlumab, is a totally new molecule addressing the CTGF, and it's in phase 3 clinical trials. Now, we don't know if this is going to make it up to clinical use after its approval. We have other Me Too drugs, like, for example, sofenidone and deupirfenidone. These are more of advanced versions of agents that have been already approved previously for the treatment of IPF. And finally, we have agents that have been approved for other indications, like treprostinil, for example, which is a prostacyclin agonist used mainly for treatment of pulmonary arterial hypertension, and venetoclax, which inhibits the BCL2, which is used in oncology. Now, we do have multiple challenges in Saudi Arabia, starting from identification, early referral, and accurate diagnosis, but also we have issues with comorbidities management. So it's very important to refer those patients because those patients are mainly elderly. I would say older adults and elderly who usually have other comorbidities such as diabetes, hypertension, dyslipidemia, and they could actually develop other complications such as right heart failure. The country here in Saudi Arabia still faces some challenges when it comes to diagnostics. One of the things is we do not have enough pulmonologists across a wide area similar to Saudi Arabia. We do not have pulmonologists in every single hospital among the 460 or 470 different hospitals. Some of them are smaller hospitals, community-based hospitals. We call them less than 50-bed hospitals in rural areas. And it's very important to educate physicians, internists, of identifying those patients and referring them in a timely fashion. The second thing is we do not have, diagnostic tests available in every small hospital. So for example, high-resolution CT might not be available in smaller hospitals or community-based hospitals or primary healthcare centers where we have most of our family physicians practicing there. However, we have worked in Ministry of Health to develop a referral mechanism that is based on referring patients from the primary healthcare center to the nearest hospital for high-resolution CT, and the family physician can actually review the report without going to the hospital to review the actual CT or radiology examinations. Now, the second important thing is to call for action in IPF. I know this is considered a rare disease. It's not an ultra-rare disease, okay? So it's actually sitting on the fence when it comes to the definition of rare diseases here in Saudi Arabia. The definition of rare diseases in Saudi Arabia that we adopted is 1 in 2,000 population, and this is actually the actual prevalence of the disease here in Saudi Arabia. In other countries, it's not considered a rare disease by any means. So it's really very important to call for action for IPF in Saudi Arabia and pave the way forward for disease awareness. And usually this comes from scientific professional societies as well as patient support groups and non-for-profit organizations. So I'm calling for action with the help of and support of the Saudi Thoracic Society, the Saudi Association for Interstitial Lung Diseases, and the Saudi Society of Clinical Pharmacy, which I happen to chair, and we're extending our arms to start the first economic burden study of Saudi Arabia, social and economic burden of the disease, and also the Saudi Pulmonary Education Group, and maybe other stakeholders who I'm not aware of. So it's very important, if you're interested or you represent one of these societies, groups, associations, please communicate with us so that we can work together in developing a national strategy to address IPF. Now, we started the first IPF disease registry in Saudi Arabia for those patients who have been diagnosed and being treated. Currently, we have different patients. I mean, we have tens of patients who have been recruited since March 2024, around 40 patients. We have already evaluated the best available antifibrotic that has been already approved, included it in our formulary, developed guidelines and criteria for use, as well as we trained multiple end users for the request of these medications. We developed also mechanisms for following up in terms of the outcomes of those patients, identifying all of their comorbidities as well in our registries. With this, I end my talk, and I would be happy to take any questions because I really have to catch a flight this afternoon. So if you allow me to take the questions now and not wait for the panel discussion. If any.
And we'll get back to it in the Q&A session. But for now, if we have any question for Prof. Al-Judai before leaving. Okay.
No questions. Thank you.
Thank you.
Appreciate it. شكرا.
Dr. Riyad Al-Abdelqawi. He is a consultant in transplant pulmonology, consultant transplant pulmonologist at King Faisal Specialist Hospital and Research Center in Riyadh, and he is the adjunct associate professor, College of Medicine at Al Faisal University, who will be talking to us on the genetic basis of idiopathic pulmonary fibrosis. Dr. Riyad, please welcome.
بسم الله الرحمن الرحيم السلام عليكم ورحمة الله وبركاته. Okay, so I thought to give myself a presentation related to genetics because I think, I don't know whether it's going to be at our time or in the generation after, that the medicine will, the way that we practice medicine nowadays is not going to be relevant in the future. So we are moving towards artificial intelligence and genomics affecting all aspects of medicine. So actually, when we think about idiopathic pulmonary fibrosis, back in the 1950, there was a report at the Chest Journal where the title was IPF is occurrence in identical twin sisters. So this was the first evidence that IPF has a link to genetics. And in 2000, there was a start of a very ambitious program in the US, and it was an international effort, the Human Genome Project. And the aim was to sequence the human genome. And it went through many phases. So the first 5 years was to develop the technology for sequencing the genome and build the computational power for the genomes. And in 1997, they recruited the volunteers to sequence their genome. So some facts that I wasn't aware until recently, that if you are to say the 4 chemical bases of the genomes, the A, T, C, and G, it would take you 100 years to finish reading the chemical bases. So, subhanAllah, we have very complex genome, and it wasn't really possible to sequence the human genome without the international effort for that. So, and in 2001, the first draft of the human genome was published. And in 2003, the final report of the human genome was published. And then was followed by the 1000 Genome Project that was announced in Cambridge, UK, because you remember the Human Genome Project was just based on a small number of subjects. And the ambition was to have more subjects to get more insight into the genome of the human, and they ended up with over 2,000 subjects sequenced. And in 2009, the 3 scientists that you see the pictures here, they were awarded the Nobel Prize for the discovery of how chromosomes are protected by telomeres and the enzyme telomerase. So telomeres are the structures at the end of the chromosomes It's like the cap on your shoelaces, because with each cell division, the body is not able to replicate the whole of the DNA. So with each division, the telomeres get shorter and shorter, and until if you don't do anything about it, then basically then the cell will stop dividing, because there will be degradation of the DNA, and then that will lead to the aging and cell senescence and apoptosis. But subhanAllah, our bodies are equipped with enzyme telomerase, where the body is replenishing the telomere sequences. There are 6 tandem sequences, A, T, G, G, G. So that will enable the cells to continue dividing. And as you can see in this figure, that the telomeres are these cap structures at the end of the chromosomes. And when you have shortened telomeres beyond the critical point, then that will lead to aging of organs manifesting as pulmonary fibrosis, liver cirrhosis, bone marrow failure, and even cancers. And if you look at IPF patients, you see that here that they have short telomeres in around 30% of the subjects. So not even just those with mutations related to the telomere genes, even the sporadic cases of IPF, around 30% of the cases are with short telomeres. And why is that important? Because one is that once you have a short telomere, then you are at risk of rapid progression of the disease, and it's well established that those IPF or lung fibrosis patients with short telomeres, they are at risk of rapid deterioration and decreased time to death or transplant. And we all remember the Panther IPF study where we were until that point practicing giving the triple medication, prednisone, azathioprine, and N-acetylcysteine. And then until 2012, when the result of the Panther IPF study was published, showing that we were doing harm to those patients. But actually, when you look at those subjects where they had DNA on them, and if you look at the telomere length on those subjects, it's only those with the telomere length below the 10th percentile, age-adjusted, they experienced the harmful effect of the immune suppression. So on the left side, you can see the red line is the placebo, and the blue dotted line is the immune suppressive treatment, and you can see how harmful the immune suppression was in terms of decreasing the survival. However, for those subjects with telomere length above the 10th percentile of the general population, there was no harmful effect. So the message here is that the short telomeres and immunosuppressions are harmful. So there's an interaction between the two. And this was replicated as well in other lung fibrosis cases. So if you look here, even the fibrotic hypersensitivity pneumonitis or the unclassified interstitial lung disease, those subjects with a short telomere below the 10th percentile, they are at a 6-fold increased risk of harm, death. Whereas those with telomere length above the 10th percentile, then at least there was no harm or there's no benefit. But the message is here that if you have a short telomere, then you're actually harming patients by giving them immune suppression. And those patients below the 10th percentile telomere length, they experience very rapid decline in their lung fibrosis, as you can see here, even without immune suppression on the right-hand side of the table. So if you had less than 10th percentile subjects, the decline per year in cases of fibrotic hypersensitivity pneumonitis was 111 mils, whereas those with normal telomere length, the decline was only 76. So those with short telomere fibrotic lung disease, they rapidly progress, and we harm them by administering immune suppressive medications. And this has led to a recommendation that we should practice precision medicine. So at least for fibrotic hypersensitivity pneumonitis, when you know that the telomere length is short, then either you don't do anything or you give them antifibrotic and avoid at all costs the immunosuppressive therapy. And if you look at the mutations for familiar cases of pulmonary fibrosis, you will find that in around 30 to 40% of the cases, they have mutations related to the telomere genes. So these subjects have short telomeres. It's only 1 or 2% they have mutations related to the surfactant. So we know that in familial pulmonary fibrosis that they are enriched for rare variants. So in genomes, you have a rare variant where the allele frequency is less than 1%, but they have a big effect on the disease. Whereas if you have a common variant where it's more frequent in the general population, they have minimal effect on the disease. And again, not just in the familial pulmonary fibrosis, even when you take cases with IPF, you still encounter mutations related to the telomere genes. And if you take all comers with IPF, at least you will get 10% with rare variants affecting the telomere maintenance genes. But there are also common variants where they are commonly encountered in the general population. If you take each variant on its own, then the effect is very minimal. But then if you put it as a polygenic risk score, so you put all the variants together and then you have the contribution of each variant, then at least you will have around 10 to 30% contribution to the disease risk. And the most common variant is the MUC5B, which was reported in the New England Journal of Medicine in 2011. And those with the polymorphism, which means that there's like a single nucleotide difference in the promoter region of the MUC5B. By the way, MUC5B is encoding protein mucin5B. So if you have that specific polymorphism, if you get one allele, then you are something like 6 or 9-fold increased risk of IPF. And if you have the two alleles, then at least there are 20-fold increased risk of IPF. And this has led to the genome-wide association study, where basically it's a case control study. So you have all the patients with IPF, and you look at the variant, and you compare it to the control, the healthy subjects, and then you identify some susceptibility loci in the genome. So there are at least around 23 susceptibility loci identified in the human genome that is increasing the risk of IPF. And why is that important? Because in the future, you might find yourself using a calculator to calculate the polygenic risk score, because IPF is a complex disease like diabetes. Nowadays, there's even scores for calculating what's your risk of developing diabetes or ischemic heart disease. Then in the future, we might have in our hands such a score. And does one size fits all when it comes to treatment? So we all aware that in the Panther IPF study, there was a third arm, which is the N-acetylcysteine alone compared to the placebo. And when they analyzed the study, actually the N-acetylcysteine on its own compared to placebo did not change the progression of the disease. But when they looked at those subjects where they had the DNA samples collected on them, and they sequenced a specific gene called the TULIP gene, which has a role in terms of the innate immune system. So actually you find that there is a group of patients where they have the CC, which is like the nucleotide in that gene, then N-acetylcysteine was harmful compared to the placebo. If you had the CT genotype, then there was no difference. But if you had the TT genotype of the TULIP gene, then actually N-acetylcysteine was helpful in reducing the progression of the disease. And this has led to the design of a prospective study called Precision's clinical trial, where they will give N-acetylcysteine only to those subjects with the specific genotype, the TT genotype. And as far as I'm aware, I haven't seen the result of that. But they'll just show you the power of the genome in deciding not just the prognosis, but also in which treatment you administer to patients. And also it has been shown even with nintedanib. So this is taken from a registry in the Czech Republic. And when they looked at the genotype of a specific gene called the DSP gene, they found that those subjects taking nintedanib and they had the G allele genotype, they had much better outcomes compared if they had the TT genotype. So it's not just one size fits approach. It's not one treatment to give into all fibrosis patients, but also it depends on the individual code of patients. And not just in terms of the treatment, but also the genomes playing a role nowadays and in the future, certainly, in helping in achieving diagnosis. So we know that we achieve the diagnosis of IPF, the usual interstitial pneumonitis, by integration of radiology, clinical, and also sometimes biopsy. But it has been shown and demonstrated that if you had looked at the gene expression at the tissue level, then that will improve the diagnostic accuracy in differentiating UIP from other forms of lung fibrosis. And you can see here how this will be integrated maybe in the future is to add some gene expression on the tissue level to help you in achieving the diagnosis. So this is a summary of the journey of the human genome. Started in 1990, the announcement of the Human Genome Project, and the first draft of that was published in 2001. And then in 2011, the FDA approved the next generation sequencing, which has enabled us to sequence the human genome rapidly and accurately. And in last year, there was the publication of the polygenic risk score for IPF. And this all started in 1950 with the first report of the familial pulmonary fibrosis in twin sisters, demonstrating the genetic contribution to the disease. If you wanted a summary slide of the presentation, it will be this one, because you can see here the power of the genetics in helping us in practicing precision medicine in terms of the screening, in terms of knowing the prognosis, achieving the diagnosis, in terms of which treatment to choose. Would you give nintedanib to the subject, or would you give pirfenidone or another medication? Would you give N-acetylcysteine to the subject or no? That all be decided by the individual genetic basis. If you are asking which patient that I subject them to genetic testing, at least the recommendation in terms of the publications of the European Respiratory Society is that you should be requesting whole exome sequencing on cases with familial forms of IPF. Familial means at least there are two members of the family where they have IPF, and also if they have an early onset of the disease less than age of 50 or 60, for example, and if you have manifestations of the telomere disease, which means that the liver cirrhosis and bone marrow failure, etc., then it's advised that these subjects should have the genetic testing. And I asked ChatGPT to draw me a picture to see how the practice of IPF will be in the future, incorporating genetics. And you can see that I think the way that we practice medicine nowadays, by giving the same treatment for everyone, every case of pneumonia, receive the same antibiotic, every case of IPF receive pirfenidone, nintedanib, that I think is definitely changing. So that will help us in assessing the individual risk of the disease, assessing the risk of progression, develop preventive measures, early diagnosis, informing the treatment decisions, and also to develop new treatments. And thank you very much.
Thank you, Dr. Riyad, for this excellent, eye-opening presentation. Now, please welcome with us our next speaker, Dr. Mohammed Sharbawishi. He is the consultant pulmonologist and head of Department of Pulmonary at a Noor Specialist Hospital in Mecca, where he is esteemed for his expertise in managing ILD cases and established a combined clinic with rheumatology in managing CTD and ILD cases. Dr. Mohammed will be talking about the highlights on IPF patient journey, diagnosis, and referrals.
Assalamu alaikum wa rahmatullah. So thank you, Dr. Hajer, for this nice introduction. And thank you for the organizing committee for having me here to present today. So my first lecture today is gonna be about highlights on IPF patients' journey. So we'll talk about more on the clinical aspect of IPF patients' journey. Ready? Okay, so I have nothing to disclose in regard to this lecture, and this is my outline. We'll touch base on the historical periods of IPF, then we'll move through the how to suspect ILD or IPF specifically. Then we'll talk about the definition and the natural history. We'll talk about also diagnosis and the prognosis and follow-up. So this is a nice timeline which illustrates the historical periods of ILD. So we can see that maybe the first possible case of an interstitial lung disease have returned back in Italy in the early 17th century, which was mainly related to occupation. A few years later, or around 1800, more and more cases have been reported. And in Germany, this is maybe the first case description of pulmonary fibrosis. In the 1930s and 40s, Hamann and Rich have described the first case of, or reported the first case of acute interstitial pneumonia, which named at that time as Hamann-Rich syndrome, which was a term that commonly described to or commonly used to describe the acute and chronic interstitial lung disease forms. More and more cases have been described and in the later on, and the distinction between the acute and chronic form is being more defined. Until also 1975, the first pathological description or classification have arrived by Lebeau and colleague. After that, the HRCT technique have been introduced in the clinical practice in the early 1980, and we can see here the literature description of interstitial lung disease have varied from using Hamann-Rich syndrome for 1980s, then the term of cryptogenic fibrosing alveolitis have raised up until the almost 1990s, and then the idiopathic pulmonary fibrosis term, once defined by the ATS-ERS classification in the earlier 2000, have been used. So these are the landmark papers and guidelines for interstitial lung disease and classification, and we can see most of them started at the 1990s, and we have the last published clinical practice guidelines in 2022. So the IPF belongs to the group of idiopathic inflammatory pneumonitis. The classification of idiopathic inflammatory pneumonitis include not only IPF, it include other pathological patterns at the NSIP, the respiratory bronchitis, ILD, the discomative IP, and the cryptogenic organizing pneumonia. These are the major inflammatory pneumonitis, idiopathic inflammatory pneumonitis. However, we have the rare and we have the unclassified. So we can see that all of these idiopathic inflammatory pneumonitis belong to the bigger picture or the bigger classification of interstitial lung disease that have not only the idiopathic inflammatory pneumonitis, but have the patient with autoimmune disease, the patient with granulomatous lung disease such as hypersensitivity pneumonitis and sarcoidosis, and the patient with other rare interstitial lung disease. So the current definition of IPF is that a chronic fibrosing interstitial pneumonia of unknown cause that is associated with a radiological and histological feature of what we call usual interstitial pneumonia. So idiopathic pulmonary fibrosis constitute almost about 20 to 25% of total of ILD causes. So what are the risk factors of IPF? The etiology is unknown, but epidemiological evidence suggests that there are a number of risk factors that is highlighted here in this diagram. So the interaction among these factors, the genetic factor, beside the environmental exposure, is really correlated with the development of IPF. Not only this, the incidence of IPF on demographic studies have been found to be increasing with aging. And also, we should note that it is more common in men than in women. What about the incidence of IPF? So there is a projected increase over the time. And basically, in a US study, the incidence is predicted to double even between the 2005 and 2030, primarily due to aging population and possibly due to advanced diagnostic modalities. So why IPF is important? So in this, we should highlight the natural course of IPF. So in a comparison for a patient with mild or moderate IPF to a healthy subject that are age 6 years and old, the average yearly decline in the forced vital capacity around 150 ml to 200 ml per year. So there is a progressive decline in the lung function among patients with IPF, and hence it's a progressive disease in nature. Not only this, IPF compared to another interstitial lung disease carries one of the worst prognosis and due to the progression nature of the disease. Based on all of these, IPF diagnosis is also associated with a very high mortality, even similar to what is seen in different cancer. We can see it's almost the third after the pancreas and lung cancer in terms of mortality. Now we'll switch gear to slides talking about the diagnosis of IPF. So the signs and symptoms of idiopathic pulmonary fibrosis are non-specific, and hence where it comes to the challenges in reaching the diagnosis in these patients. The symptoms could include dyspnea, which is the most common symptoms, cough, fatigue, weight loss, chest pain, anxiety, and these are the symptoms also from the New England Journal of Medicine. I'll just want to emphasize that the finding of the fine inspiratory clackers, or what we call the Velcro crackles, on exam should really make the diagnosis of interstitial lung disease, mainly IPF, is a possibility. And these are one of the earliest signs on physical exam. So again, non-specific symptoms and signs. Hence, the misdiagnosis is usually common, and the delay of referral is the result. So what about the role of physiological testing in mainly the pulmonary function test? It aids in the diagnosis, although the pattern of abnormality is non-specific. This non-distinguished IPF from another ILDs. However, baseline test may provide us an estimate of the prognosis, as here in pooled analysis of patient who did not or who were in the placebo group of different clinical trials, the patient whom shown the more advanced decline in the lung function have the higher risk or the greater risk of mortality. Not only for the pulmonary function test, but also for the 6-minute walk test. So baseline and follow-up of 6-minute walk test have shown that patients who have desaturated to less than 85 and patients who have a predicted or who have less than 300 meter in distance have a greater increase in mortality. And this is also applied in our population by a study by Prof. Al-Hamad. So serial testing is recommended for also determining progression. So these conclude the role of physiological testing in IPF. So what's the patient journey looks like? So the first encounter of a patient with an ILD or idiopathic pulmonary fibrosis are usually the general practitioner or the family medicine. So that patient usually being examined for routine or unrelated issues, have been treating many times for other differential diagnoses such as infections, such as an airway disease, prescribed an inhaler, and so on. So the referral, until the patient is referred to a pulmonologist, there is usually some delays, and we will talk about that in another lecture. Once the patient have also reached the local pulmonologist, again, some delay can be there until the diagnostic testing is taking place, including radiological, physiological, and so on. So until the patient is being referred to the specialized clinic, the waiting time and so on, we can see that there is considerable delaying in the IPF patient journey until they get their final diagnosis. These are the common other diagnoses that usually IPF patient came with. So many patient diagnoses, asthma, pneumonia, bronchitis, and so on. Also, as a result, again, as we said, the misdiagnosis is common, and the significant delay is common. Sometimes time to final diagnosis, the median is 11 months. It reached up to 2 years in some studies. And how does this referral delay impact on the patient? We can see it is correlated with the survival, as described earlier, even in 2011 by Lamas, and furtherly confirmed in newer studies, as we will see. So, diagnosis of IPF, the current guideline, these are the basic of diagnosing IPF. So it depends mainly on exclusion of other non-interstitial lung disease causes and the presence of an HRCT pattern of UIP, or the specific combination of the histological, histopathological, and radiological pattern. Of course, we should highlight the role of multidisciplinary discussion in IPF, as we will see maybe come on in another lectures. So the diagnostic algorithm for IPF. So patients suspected of having IPF. So any patient is suspected to have IPF, a detailed history and physical examination should be taken, considered. And this is what also was recommended in the 2018 guideline of IPF. So detailed history should include exposure and occupation and smoking, should include medication, should include connective tissue disease signs and symptoms, and also family history of IPF. So targeting or not to know whether there is underlying known cause or not. What about investigation needed at baseline? Again, the guidelines have a statement on that. So the baseline serological tested needed at that time include the inflammatory markers, the autoimmune in terms of ANA, rheumatoid factor, and anti-CCP. The other serological and autoimmune workup should be individualized as case by case according to the history and physical examination. So do we need to refer every patient to rheumatology at the initial step? Again, we have a statement on that, and there is differences in the practice in this pattern. However, most of the patient is not being referred to the rheumatology unless they have sign or symptoms suggestive of connective tissue disease, or have the serological test positive, or there in some clinical practice there are some CTD questionnaires are being used, and if the questionnaire is being positive, these patients should be seen by the rheumatology. So, the diagnostic algorithm, if the patient is found to have a confirmation of a specific diagnosis, meaning that he have an alternative diagnosis, so he has no IPF, we're dealing with something else. What if the patient does not have an alternative diagnosis? Here it comes to the HRCT pattern. And the primary change in the updated algorithm from 2022 is that patients with probable UIP or UIP are now treated the same. So briefly, we'll talk about the definition of a UIP in terms of radiologically. So the distribution usually is a subpleural and basal predominant, usually with normal lung in between, and there may be asymmetrical. The CT feature composed of honeycombing with or without traction bronchiectasis, and the presence of irregular thickening, the subpleural thickening and the interlobular septa, and usually superimposed with reticular pattern and mild ground glass opacity. What about the definition of the probable UIP? Again, the distribution is almost the same, subpleural and basal predominance, and again, it's often heterogeneous. The CT features composed of the reticular pattern with traction bronchiectasis and bronchiectasis. It may also have some mild ground glass opacity, but there is absence honeycombing and absence of subpleural sparing. So, after the HRCT pattern showing UIP or probable UIP pattern, here it comes the role of multidisciplinary discussion before diagnosing or labeling the patient as an IPF. So we can see that the multidisciplinary discussion have been implemented in the diagnostic algorithm in many steps, not only at the final decision. So what about the rule, what if the patient have indeterminate pattern for UIP or alternative diagnosis? The indeterminate pattern is defined as CT features of lung fibrosis do not suggest any specific etiology, and the alternative pattern the finding that suggests another lung disease such as cystic lung disease, the presence of mosaic attenuation which suggested airway or hypersensitivity pneumonitis, or the predominance of ground glass opacity that suggests the non-specific inflammatory pneumonitis. So what if we have this pattern on CT? The next step is again to discuss them on the multidisciplinary discussion that is usually composed of a pulmonology and radiology at this step, to discuss what is the optimum next tissue sampling technique, which is again highlighted in the guideline. So the role of BAL in bronchoalveolar lavage in those patients is to exclude infection, to exclude other differential diagnoses, and the role of transbronchial biopsy, which is now there is emergent evidence on such newer technique as it is implemented in the guideline with the statement that these patients the guideline have said that this is an acceptable alternative to surgical lung biopsy in patient with suspected to have IPF. There is also a guideline by the European Respiratory Society talking about the transbronchial lung cryobiopsy. And we can see that they already implement the transbronchial lung cryobiopsy as an alternative to surgical lung biopsy in a stepwise approach in even in patients who are eligible for the surgical lung biopsy, and the only option for patients who are not candidate for surgical lung biopsy. And this is what even supported by a recently published randomized control trial in July 2024, 1 month ago, the COLD study, who have divided the patient into 2 groups, the stepped up strategy with the transbronchial lung cryobiopsy followed by surgical lung biopsy, and the patient who did surgical lung biopsy from the beginning. And we can see in terms of outcome result, not only the diagnostic yield is slightly, but not statistically significant better. However, the side effects profile of transbronchial lung cryo is much less than surgical lung biopsy. And this is the side effect of the both procedures. So this graph also combined the histological and the radiological diagnostic pattern of an IPF if you have both. I'll not spend too much on that time. So few words about the prognostic score. So the GAP scoring system have been validated and used in following up the patient and determining their prognosis. However, since the physiological testing have also an impact on the prognosis, we have now a modified GAP, or what we call the dyspnea oxygen gap index, which basically they added the 6-minute walk test parameter, including the oxygen. And it is found to correlate better in terms of mortality assessment or prediction than the GAP. So the natural course of IPF, again, we can see that patients have variable course. Patient may have slow progression, they may have rapid progression and declining from the beginning, and they have patients who have an exacerbation and becoming worse after that. Just one slide about the comorbidities. So in a recent study, as mentioned by Prof. Al-Jadel earlier, the comorbidities are common in patients with IPF, and 60% of patients may have 1 to 3 comorbidities, and 30% have even up to 7 comorbidities. So it's a complex disease. And these are the causes of death, usually in IPF. Most of them are died because of an acute exacerbation. So this is my take-home message. In brief, the evaluation of ILD begins with a thorough history and physical examination targeting the connective tissue disease symptoms, particularly for rheumatoid, inflammatory myositis, and scleroderma. Occupational and exposure history is important along with the medication. All patients should undergo testing for autoimmune disease. BALI is useful in non-fibrotic. Transbronchial lung cryobiopsy is emerging. The multidisciplinary discussion improved the diagnostic confidence. So with this, I conclude my talk.
Thank you very much, Dr. Mohammed, really for this brilliant presentation, taking us day-to-day work for our patient with IPF. Now, please welcome with us Dr. Abdullah Asiri. Dr. Abdullah Asiri, he is the internal medicine and respiratory consultant, assistant professor in Baterjee Medical College, head of respiratory and TB unit at Asir Central Hospital. He will be talking about the importance of early diagnosis and treatment of IPF. Please welcome Dr. Abdullah Asiri.
Thank you, Dr. Hajar. First of all, I would like to thank the organizing committee to inviting me to be a part of this conference today. Actually, I will talk about the early diagnosis and the importance of the early diagnosis of patients with idiopathic pulmonary fibrosis, as mentioned by the previous speakers, that the idiopathic pulmonary fibrosis is a chronic, progressive, fibrosing interstitial lung disease of unknown cause. It is irreversible, late diagnosis, and it's rare. And the prevalence of IPF appears to be increasing, although it's unclear whether this reflects the increased recognition or a true increase in the incidence. The prognosis is poor, as mentioned by Dr. Muhammad, and despite the development of antifibrotic medications to slow the disease progression, the IPF can ultimately be fatal disease, and early diagnosis is crucial for initiation of treatment and to refer for a palliative treatment and even the early referral for a possible lung transplantation in a specific group of patients. So, as they mentioned, the IPF, it's depends on the clinical presentation. The clinical presentation and specific. Majority of patients, they present with general symptoms like cough, shortness of breath, and which is misdiagnosed as asthma or COPD, which is quite common. Pulmonary function tests, we can depend on high-resolution CT, and a lot of guidelines were created regarding the role of high-resolution CT, which is discussed earlier by Dr. Muhammad. So the most important thing is very important that majority of patients, they are first evaluated by the primary healthcare physicians, and I think increase the awareness among the primary care physicians is very important and crucial regarding the early detection of IPF. So, as I mentioned, that the primary care physicians, they have to be trained regarding the early detection of idiopathic pulmonary fibrosis, and it's very important to train them and create a clear pathway regarding the patients with suspected IPF to refer them earlier to ILD specialized center. We found that in the lung cancer screening programs, they found some of patients, they have a background of what they call it interstitial lung abnormalities, and they create a recommendation regarding those patients to identify or investigate more regarding these abnormalities by high-resolution CT to detect if those kinds of patients have ILD or idiopathic pulmonary fibrosis or UIP beta. So when you treat the IPF, it is important to start the early treatment because the antifibrotic, either pirfenidone or nintedanib, show decrease in the progression of the disease, especially as reflected by forced vital capacity. And we know that the pirfenidone was evaluated in both capacity and ascent trials, and it show delay the progression of decline in the forced vital capacity, and also in the nintedanib in the impulse trial. So early diagnosis maybe lead to earlier treatment, and even individual clinical trials were not sufficient because a lot of patients who are involved on these trials was either late diagnosis or have advanced disease. Evidence is growing supporting the effects of anti-fibrotic, decreasing the risk of acute decline in the lung function and improving the life expectancy by slowing the progression rate of IPF. And given the progress of a patient's condition cannot be anticipated at the diagnosis, and considering poor overall prognosis of untreated IPF, antifibrotic medication should be considered for all patients with diagnosis of IPF. Futures outlooks, as Prof. Al-Jadeh talk about, that there is medications that can now is involved in multiple clinical trials, and involvement of a combination treatment in a patients with IPF by pirfenidone and nintedanib showed that there is increase in the gastrointestinal side effects, but a lot of evidence that is coming supports the using of antifibrotic medications. Take-home message, the IPF is a rare disease and can be difficult to diagnose. Access of to antifibrotic is restricted to a patients known to specialized centers, and such any delay in the referral of ILD might will lead to poor prognosis and death. La qaddar. Specialized multidisciplinary team review of a patient's and discussion of individuals' risk and benefits of treatment may help the patients with adherence to a medication. Thank you.
Thank you, Dr. Abdullah Asiri, for your excellent presentation. Now, please welcome with me Dr. Mohammed Al-Ghamdi. He's a consultant in pulmonology, critical care, and interstitial lung disease at King Fahd Medical City in Riyadh. He will be talking about the global guidelines on managing IPF. Please welcome Dr. Al-Ghamdi.
Assalamu alaikum. يعطيكم العافية جميعا. I'm happy to be here and thank you for the opportunity. So before we go over the guidelines of IPF, we will just shed a light about the main trials that have formed our treatment of idiopathic pulmonary fibrosis. And as you can see, although the idiopathic pulmonary fibrosis is a chronic disorder and it is not uncommon, unfortunately, the studies that have made the way that we treat IPF right now have only started to show up in the last 20 years. So if you look at the first trial that was of value, it was only reported in 2005. This is very different from what we see in the other chronic disorders like heart failure, liver cirrhosis, etc. Now, when we zoom in into the most important studies that have informed our decision making, Iphigenia trial was published in 2005, and it had two arms. The first arm was N-acetylcysteine plus prednisone and Imuran, and the other arm had prednisone and Imuran alone without N-acetylcysteine. In that study, the group of patients that have received N-acetylcysteine in addition to steroid and Imuran had a lesser decline in the FVC and DLCO. On that basis, the same group of authors have published Panther trial in 2012. And on that study, the authors grouped the patient into three groups. Group 1 had placebo alone as a treatment for their IPF. The second group had N-acetylcysteine alone. And the third group had N-acetylcysteine in addition to prednisone and Imuran, similar to what happened in the Iphigenia trial. In this trial in Panther, and after the recruitment of the first 60 to 80 patients, they had to discontinue the trial because of harm that was induced and inflicted upon the patient. There was an increase in the mortality, so they had to abandon the study. And from that time and on, the anti-inflammatory medications are no longer treatment option for patients with idiopathic pulmonary fibrosis, except in the cases when there is an exacerbation, and that is a different topic. They actually continued the two other arms of the study, the N-acetylcysteine versus placebo. And on that arm that was an extent of PANTHER trial, the study revealed that the addition of N-acetylcysteine, or the arm that contained N-acetylcysteine versus placebo, did not preserve FVC and DLCO over time. So at that time, N-acetylcysteine was also removed for the treatment of idiopathic pulmonary fibrosis. Now, the basis of the use of N-acetylcysteine was the mechanism of N-acetylcysteine that is presumed to limit cells injury. When it was tried on IPF patient, it did not work. So the first hope that we started to see was in 2011, when the two phase 3 trials of IPF were conducted, Capacity 1 and Capacity 2. Unfortunately, the study resulted in mixed result. Both were multinational. One study was positive, and the other study was negative. So the FDA mandated the same group of authors to actually conduct a new study. Tomorrow's study in 2011, same year, was this study of nintedanib efficacy study, phase 2, not phase 3. It was like a dose finding, efficacy finding kind of a study, and it showed that the treatment, which is nintedanib, is safe to use, and it slows the disease progression or the decline of FVC over time. It was an efficacy recommendation was made by the American Thoracic Society regarding nintedanib at that time. And in the same guidelines, they recommended not to use pirfenidone because of the mixed result. In 2014, the Impulses 1 and Impulses 2 were conducted. Both trials were concurrent multinational studies using nintedanib in one arm versus placebo in one arm. And that study was positive, showing modest effect in reducing or slowing the disease progression over time. Ascent trial was the answer of the authors to the FDA when they mandated the authors of pirfenidone to repeat their study. So they conducted the Ascent trial, and they finally showed that there was benefit of adding pirfenidone to patients with IPF in terms of slowing the disease progression over time. The group of authors that conducted Tomorrow and conducted the Impulses trial gathered all the data, and in 2015 they published a reanalysis of the combined data, and the benefit of nintedanib remained there and remained positive. So these are informed our decision making in IPF, and if you compare this with any chronic disorder that you know about, this is really a scarce, like limited number of trials and data. So there is only one comprehensive global guidelines. It's led by the American Thoracic Society, and it is published in their documents or their papers. It is a conjoint effort of the American Thoracic Society, the European Respiratory Society, the Japanese Respiratory Society, and the Latino Respiratory Society, or the ALAT. So they actually have a group of authors or experts from each society, and they form a conjoint guidelines. In 2011, at the time of the first trials of antifibrotic medication, they released their first IPF specific. In 2015, they gave it a general update after the conduction of the phase 3 trials of pirfenidone and nintedanib. They gave an update about the diagnosis of IPF in 2018, when we started to use cryo biopsy, and when we started to use multidisciplinary discussion in making the diagnosis of IPF. And in 2022, they gave their latest update to the guidelines of IPF after we had more experience with cryobiopsy and more experience with MDD diagnosis of IPF. So this is the 2000, and at that time they gave a conditional recommendation to use pirfenidone in IPF patient, and a conditional recommendation to use nintedanib, and that was the first time that there is an established antifibrotic treatment for patients with idiopathic pulmonary fibrosis. In 2018, they made a diagnostic procedures recommendation, and they divided the patient into the group that had EUIP pattern on CT scan and the group that had the other patterns of CT finding in IBF or ILD patients. And the patients with UIP, they recommended or they suggested not to do PAL, to do surgical lung biopsy or cryobiopsy because the diagnosis is already there. In terms of the patient who has no UIP but other patterns, they suggested to do BAL or bronchoalveolar lavage, and they did not recommend for or against the use of cryobiopsy or transbronchial lung biopsy because the cryobiopsy at that time was just started. The yield was not as good as now, and the side effect profile was huge. The risk of bleeding was up to 40%. The risk of pneumo was close to 40%, and the risk of bleeding is close to 15%. For both patients, the patients with UIP and non-UIP, they recommend a thorough investigation, as my previous colleagues mentioned, and connective tissue disease workup, and a multidisciplinary discussion to make the diagnosis of IBF versus the other conditions. And since that time in 2018, the multidisciplinary discussion diagnosis of IBF and ILD in general has become the standard of care. In 2022, they have updated the previous statements, and it was a focused update. They specifically mentioned that cryobiopsy now can be regarded as an alternative to surgical lung biopsy in the patients who have ILD with undetermined etiology. And this is because of the improved yield over the years and the better safety profile with these procedures. They also suggested not to treat IBF patient with anti-GERD treatment or PPI for the sake of improving their respiratory symptoms, because there are actually no strong evidence to support that. They also suggested not to refer your IBF patient for anti-reflux surgery for the sake of improving their respiratory symptoms, because again, there are no finding that supports doing so. If your patient has symptoms of GERD or has radiological findings or scope findings of GERD, go ahead and treat. If not, you don't treat. They established or adjusted the different CT patterns and the description for it, and we have already gone through that in previous lectures. And they did not make any changes to the histopathological patterns of ILD. So this table is derived from the 2018 statement. They just put a specific update to the pathway of diagnosing IPF in 2022, which is the inclusion of probable UIP as a very close pattern to UIP. And in certain conditions, it is enough actually to make a diagnosis of IBF based on that probable UIP pattern. And they specifically said that if the clinical setting is right, and you have a probable UIP, and the ILD MDD team agrees that the IBF is the most likely diagnosis, go ahead, forgo biopsy. The post-test probability of diagnosing IBF, if you happen to do a biopsy, it's above 80%. They specifically said that the right clinical setting is having a patient who is male, who is above 60, who is a smoker, who has GERD. So you have to have the right clinical setting. If you have a probable UIP picture, but the patient is female and her age is 50, that doesn't work, right? So don't take it easily. having a probable UIP doesn't always mean IPF. You have to have the right clinical scenario, right? The risk factors are there. The patient is male, the age is above 60, the patient is smoker, etc. The Fleischner Society group of authors in their white paper, they actually gave a better description to this right clinical setting. And they specifically said that the patients are above 60, they have no exposures of interest, either occupational or environmental, and that they have no connective tissue disease symptoms or sign. It was a clear description to this right clinical setting. So if you have it and you have a probable UIP, and the group of experts during the ILD round thinks or believes that the diagnosis is IBF, you call it IBF. If your patients have exposure to farm, like a hay, moldy hay, or he has a bird, and the age is like 58, and the patient is male and has probable UIP, you are not supposed to call it IBF, and you're supposed to do further investigation. Now, this table is only gets into practice when you have both histopathology and radiology. Otherwise, it is of no use. The only thing that I would like to make a clear statement about is what to do when you have the light green color diagnosis, which is suspected IBF. When you have suspected IBF, there are certain features that if you have, it or upgrade your diagnosis from IBF, from suspected IBF to definite IBF, and this has already been clearly defined in the American Thoracic Society statement. So if the bronchiectasis is moderate to severe, that's one sign that elevates the diagnosis from suspected IBF to definite IBF. If the patient age is above 70 and the extent of fibrosis is more than 30%, then that also elevates the diagnosis or increase it or make it definite instead of suspected. If the patient has no lymphocytosis in bronchoalveolar lavage or increased or abundant neutrophilia on bronchoalveolar lavage, this also makes the diagnosis definite instead of suspected. And if the ILD group of experts during the ILD MDD round group of experts believes that the diagnosis is actually IBF, this also upgrades the suspected IBF diagnosis and makes it a definite IBF. They also described the patient journey in terms of diagnosis and then surveillance and treatment. Over that, because we have already done that. Beside the global IBF guidelines, there are some local IBF guidelines. There is actually no much difference in terms of the recommendation when you compare the global one, and that's because of the scarcity of the evidence to support the generation of guidelines. This is the CPAR, the IBF guidelines of the Spanish Society. This is the British one made by NICE, and this is the South Korean one, and we have more than that. And thank you very much.
Thank you, Dr. Mohammed. We are going to break, but before the break, I encourage the audience to write down their Q&A questions. We are going to have Q&A session after completing the event. I would like to ask our speakers group photo. Then we're going for prayer and break for 45 minutes, and then we'll reconvene. Thank you very much. We'll reconvene at 1 p.m. inshallah. Thank you. Okay. Assalamu alaikum and welcome back. Now we are continuing our program with our prominent speaker, Dr. Walid Swayan. He is the pulmonary medical and pulmonary rehabilitation consultant at Security Force Hospital and the head of pulmonary division at Security Force Hospital. Please welcome with me Dr. Walid Swayan. He will be talking about the current management of IPF. Dr. Walid, please.
Okay. Thank you very much, Dr. Hajar, for the nice presentation. Thank you for the attendee. I'm very happy and glad to be with you. To be honest with you, my colleague made my life easy because they covered a great proportion of my talk. So in the coming 15 minutes, I will speak about the current management of idiopathic pulmonary fibrosis. As mentioned before, IPF is a progressive fibrotic lung disease characterized by worsening respiratory symptoms as well as physiological impairment. It is a specific form of ILD with radiological and histological pattern of UIP in the absence of environmental factors and other known causes of ILD. As mentioned by Prof. Jdeer, the estimated global incidence of IPF range from 1 to 13 per 100,000 person, and the prevalence range from 3 to 45 per 100,000. And the highest number globally reported from South Korea and North America. But remember, one of the vision of our country is to increase the lifespan of the community. So we are expecting the IPF to move from the rare disease soon. Risk factors are also discussed with my colleagues. Remember, always think about IPF when you face a patient who is older than 60 years of age. It is more prevalent in male. Dr. Raed, he went thoroughly through the genetic risk factors in all levels, starting from the host defense, telomere maintenance, surfactant processing, epithelial integrity, as well as fibrotic signaling. I will not go through these since my colleague Dr. Raed discussed it already. Remember, there is a strong association with cigarette smoking, air pollution, and occupational exposure, so you have to focus in the history when you look for a patient who has IPF. And also remember, there is a significant comorbidity, including gastroesophageal reflux as well as obstructive sleep apnea. And these diseases are very prevalent, but still the causative role hasn't been clearly established. Family history is very important also. The most important first step is to establish the diagnosis, since misdiagnosis can lead to inappropriate initial therapy. The diagnosis of IPF may be established with a high degree of confidence in patient with a compatible clinical presentation plus typical features of high-resolution CT scan. So if the high-resolution CT scan showed definite pattern, then you can diagnose your patient. If you are still in doubt, then you have to go a further more with more diagnostic workup, which should include pulmonary function test, 6-minute walk test, bronchoalveolar lavage, and plus minus surgical lung biopsy, or the other alternative is transbronchial lung cryobiopsy. Just to revise with you, in the left photo, this is a typical UIP pattern. Clearly, there is subpleural lower lung predominant reticular abnormality with honeycombing and traction bronchiectasis. So this is typical UIP. In the middle photo, this is a probable UIP, and you can see that the pattern is peripherally located with numerous bronchiectasis, but in the absence of the typical honeycombing. In the right photo, this is the indeterminate for UIP pattern. Here you see that there is a heterogeneity with subpleural lung infiltration, but you see clearly that there is a significant amount of ground glass opacity. So this is definitely indeterminate for UIP, and you need to investigate your patient more and more. Treatment options, there is pharmacological medication available in the market, FDA approved, and there is also non-pharmacological management. The pharmacological management include the two important medication, nintedanib and pirfenidone, and in the non-pharmacological treatment, we should look for the indication of supplemental oxygen for our patient, and most of the indications of oxygen therapy in the field of pulmonary medicine came from COPD studies. Pulmonary rehabilitation is another very important aspect of treatment. Pulmonary rehabilitation per se showed to improve clinical outcomes in patients with IPF, including improved shortness of breath and the quality of life. It is very important to look for the nutritional status of our patient and adjust the weight. Vaccination is a very, very, very important aspect when it comes to the management of IPF, and eventually when the patient at the level of lung transplantation, it is very important to think about it and refer him as early as possible if he has the indication to go for lung transplantation. The validation of the two important medication, starting with pirfenidone, came from many trials. The capacity trial, which was published in 2011 in The Lancet, showed clearly that the pirfenidone reduced the decline in forced vital capacity when we compare it with the placebo. And it also improved the progression-free survival, and also it reduced the rate of decline in the 6-minute walk test. And the studies showed clearly that the commonest side effects include GI symptoms, photosensitivity, and rash. 2014, in the New England Journal of Medicine, the ASCEND trial came, and it showed almost the same result, that the pirfenidone reduced the disease progression, reduced the rate of decline in 6-minute walk test, reduced the risk of death at 1 year by almost 50%, and improve the progression-free survival. I want to remind you that the pirfenidone is antifibrotic agent that inhibit the transforming growth factor beta, stimulated collagen synthesis, and block fibroblast proliferation. The dose of pirfenidone range up to 40 milligram per kg per day to a maximum of 2,403 milligram per day in 3 devices, divided doses. So always there is an issue with compliance when it comes to the pirfenidone, because the patient has to take it 3 times per day. The other validated medication is nintedanib, and nintedanib is a receptor blocker for multiple tyrosine kinases that mediate elaboration of fibrinogen growth factor. It was studied in many studies. Tomorrow study in 2011 showed clearly that nintedanib, when you compare it with the placebo, reduced the decline in the forced vital capacity, reduced the disease progression, improved the quality of life, and the side effect more or less the same of pirfenidone, GI symptoms as well as elevated liver enzymes. In the Impulses trial, which was published in the New England Journal of Medicine 2014, again, nintedanib showed a reduction in the rate of decline in the forced vital capacity, and it showed clearly improvement in the quality of life, and the side effect was almost the same like pirfenidone, GI symptoms with elevated liver enzymes. So when we should start the treatment? Shall we wait and watch, or shall we start the treatment as soon as possible? And the literature showed us clearly that we should initiate the treatment as soon as possible. Why? Because IPF has a poor prognosis. The median survival at the time of diagnosis is 3 to 5 years, which is worse than many cancers. And again, in IPF, it is always unpredictable behavior. Some of the patients, they will progress very rapidly, and some of them, they will progress slowly. So you cannot predict which is which. So it is always advisable to start the antifibrotic as soon as possible. IPF clearly showed a progressive decline in the forced vital capacity. When you compare the IPF patient with the normal individual, the normal individual, the rate of decline is almost 20 to 30 ml annually. When you see for the IPF patient, it is almost 200 ml. And the change in the forced vital capacity is associated with increased mortality. If there is a change more than 10%, decline more than 10%, this is associated with 5-fold increase in the risk of mortality over the subsequent year. Not only that, but when we looked for the studies conducted by Birferidone and Nintedanib, for example, this study, which was published in 2016, looked for the efficacy of Birferidone in patients with idiopathic pulmonary fibrosis with more preserved lung function. They categorized the groups to two groups: the patient with more preserved lung function, I mean forced vital capacity more than or equal to 80, with a GAP stage 1, and the other group with less preserved lung function, with a forced vital capacity less than 80 and a GAP stage 2 to 3. And what they found, that there was a clinical significant disease progression at 12 months in both groups, and the magnitude of Birferidone treatment effect was comparable between subgroups. So it is advisable by this study to initiate Birferidone as early as possible. What about Nintedanib? Also another study published in 2017 in the Thorax Journal looked for the Nintedanib in patients with idiopathic pulmonary fibrosis with preserved lung volume. And again, they categorized the patient based on the forced vital capacity, more than 90 or less than 90, and the result was almost comparable. The treatment with Nintedanib showed the slowed the annual rate of decline in forced vital capacity in both groups to the same extent. So if you initiated Nintedanib early, the result is always promising. So when we should we stop the treatment? There is two indications. Number one, if there is unbearable side effect, and number two, if there is lack of efficacy. And what do we mean by lack of efficacy? In the literature, they define as an absolute decline in the forced vital capacity more than or equal to 10% after 6 months of treatment. So this is indicate an inadequate response. So surgery, as you know, may expose the patient to a significant risk of acute exacerbation, which may occur in 20% of the cases. It is always come to our practice, shall we stop the antifibrotic treatment for the patient who is going for surgery? And this study assessed the risk of efficacy and safety of perioperative Birferidone for prevention of acute exacerbation of idiopathic pulmonary fibrosis in lung cancer patient undergoing pulmonary resection. So what they did in their study, they gave the Birferidone until the morning of the surgery and then restarted as soon as possible when the oral diet given to the patient. And there was no serious adverse event observed, and the acute exacerbation of IPF didn't occur in 37 out of 39 of the patient, which is a good number, because when you look for the literature, usually the risk of acute exacerbation after surgery reach up to 20%. I will conclude with a very nice retrospective cohort study published by our colleague from the National Guard Hospital. They looked for their real-life data regarding the Nintedanib and Birferidone. Just I will share with you two important. It was published recently, 2023, in the Annals of Thoracic Medicine, and I found it very interesting because what they noticed in their cohort study that there is increase in the number of hospital admission in the group started with pirfenidone when they compared them was started on nintedanib. And number two, regarding the side effect, both of the medication known to cause GI side effect, but what they noticed in their cohort that the patient with nintedanib usually they have lower GI symptoms, and the patient with pirfenidone they have more of upper GI symptoms in the form of nausea and vomiting. So to conclude, disease with high mortality, antifibrotic are not curative but effective. Early treatment initiation is important. Always monitor for the sign your patient for lung cancer. Thank you very much.
Thank you very much, Dr. Swayan. Really very important messages in the management of IPF, reflecting on the patient outcomes. Now, please welcome with me Dr. Sultan Ganesh. Dr. Sultan is a consultant in pulmonary and sleep medicine at King Abdulaziz Medical City in Jeddah, and he will be talking to us about IPF management in real practice, a case discussion. Please welcome Dr. Ganesh.
Bismillah ar-Rahman ar-Rahim. Thank you all for being with us today, and thank you for organizing the committee, and thank you for Dr. Haji for this nice introduction. I'm not sure if you have something just to prevent my restriction in the movement. I don't like to be, but on mic. Thank you. My presentation is going to be like an interactive session. So we are going to talk about the case faced during our clinical practice. And I think our colleague in the previous lecture made everything easy for us. Okay, so let's start. So I will start with we have nothing to disclose. And this is my outline. So we'll start with a few slides of introduction, then we'll start with the case discussion and how we apply the guidelines in this case. So as everybody knows that we have a variety of the interstitial lung disease, and this interstitial lung disease can vary based on the geographic distribution or based on the gender and the age of the patients. And the most studied type of ILD is the IPF. And we have to know that some of these ILD patients, usually they progress over the time, and this is why we have now what is called progressive pulmonary fibrosis. So I think everyone knows this slide or this diagram and how we can classify the ILD, and usually we use this diagram to approach our patient in the ILD. I will not go through it. Also, already my colleagues went through it. So let's start with the case presentation with no delay. So my patient is a 74-year-old gentleman, former smoker, presented to my clinic with a shortness of breath and cough for 8 months. He has no chest pain and no orthopnea or PND. He has no constitutional symptoms. There is no history of occupational and drug-induced lung toxicity. He has no symptoms suggestive of connective tissue disorder. So going through the past medical history, he has hypertension, diabetes, hypothyroidism, and GERD. Past surgical history is significant for appendectomy. And family history, his father died from heart disease at the age of 84. Socially, he quit smoking 15 years ago with the history of 1 pack per day. He is retired and he was a teacher. Vitally, when he presented to the clinic, almost stable, oxygen saturation 92% on room air. He has a finger clubbing. Chest exam showed basal crepitation with a normal cardiovascular exam and the other examination as well. Lab work. as our colleague advised, we did our lab work, including the basic and the serology. For the basic CBC and renal and liver profile were normal. Serology were negative for ANA, anti-CCB, and rheumatoid factor. So this is the main basic we ordered. So because the patient has a chronic progressive shortness of breath and crepitation or signs of interstitial lung disease, in the exam, we did the chest X-ray. So just we need your help to interpret what we have in this chest X-ray. Anyone? عادي هو sessions friendly sessions زي ما يقولوا. We can say anything. طب في تفضل دكتورة. Okay, excellent. So we have increased circulation bilaterally. Okay, what else? Shaggy heart border, okay. We can agree on that. What else? So let's say if we're thinking about the interstitial lung disease and based on the age and based on the symptoms so far and the serology that has been negative and negative history for connective tissue disorder, we think now about usually IPF. But do you think that patients with the IPF having normal lung volume? So there is no losing of lung volume in this patient. What do you think? What happened? Okay, let's just proceed and see. This is the BFT. So, can we pointer here? Do you have pointer here? Okay, just if you see here, for vital capacity 67%, FEV1 72 ratio is normal. This goes likely with the restrictive pattern, but we have to see the total lung capacity. Total lung capacity here is 64%, so it's reduced with the reduced RV. DLCO here is 41%. We did a 6-minute walk test for this patient. The patient has significant desaturation on walking down to 84%. So what do you think from what we have so far? What should we do next? High resolution, for sure we'll do high resolution CT. Okay, in addition to the high resolution CT, echo, why? Pulmonary, looking for what? Pulmonary hypertension. Is there any clue here say that there is a pulmonary hypertension? Yes, excellent. Yes, this is urge us to do echocardiogram because there is out of proportion reduction in the DLCO comparing to the vital capacity. This is why we think about the pulmonary hypertension, okay? The second things here, if you see what we have in this patient, so the lung volumes is abnormal, but in the upper abnormal range. So, or we can say little bit below the normal range here. So we did echocardiogram, right ventricular systolic pressure is around 55, so it's high. So what's next? Already the doctor said we'll do CT scan. So this is the cut of the CT scan that we have. So just only we have few cuts. So any volunteer or you want me to go through it or it's up to you? طيب واضحة السي تي ولا شوية عشان يمكن اللايت؟ طيب. So what we have, I will talk about the ILD finding here, then we'll go back why the patient has a normal lung, normal lung expansion in the X-ray, let's say. It's not normal, but near to normal, let's say. So we have like subpleural reticulations, we have some traction bronchiectasis in some area, and we have some area of the bronchiectasis and area of honeycombing. So this is usually goes with the UIP pattern. I don't have the whole cut, to be honest with you, to present everything. But the other things that is very important here, Also, if you notice here, there is no much losing of lung volume in these patients, and this is because the patient has something in the upper lung. What is it? So the patient has emphysema. So the scenario now is typical with which diagnosis? Is a combined disorder. So this is the typical with the severe or moderate to severe pulmonary hypertension in those patients. So we have to pay attention to this entity if we consider it one entity, because some physicians say that this is not one entity, this is a different entity. But if we consider it, we have to pay attention because it's associated with the high mortality. So what's the diagnosis? Is a combined pulmonary fibrosis and emphysema. So I believe that our colleague went through this algorithm, and this is what we did in our presentation, in our case. We did a detailed and comprehensive history and physical examination that followed by some serology tests, and based on what we have, we did a CT scan to say if the patient had UIB or probable UIB, and after MDD, we can say this is IPF or there is alternative diagnosis. So just one slide about the combined pulmonary fibrosis and emphysema, because IPF is common in those patients with history of smoking. Also, those patients may present with the emphysema. So sometimes subnormal or near to normal PFT doesn't exclude this high or progressed disease or severe disease in those patients. So we have to collect all the information together to make our decisions. So those patients usually, they have heavy smoker history, they have hypoxia mainly on walking, and upper lobe emphysema with the lower lobe fibrosis. There is unexpected subnormal lung volume and severe reduction to the DLCO. Usually, high-resolution CT can diagnose the entity. Okay, in different way of presentations, I think Dr. Mohammed Al-Ghamdi presenting most of these studies, and these studies just say what has been approved as a medication for IPF, including the pirfenidone and nintedanib. Sorry, I think there is a movement in the highlight after changing the slide, but we are talking mainly here, the only medication that has been approved is pirfenidone and nintedanib for IPF. What about those patients with the combined fibrosis and lung emphysema? So still, we don't have a good evidence to start these antifibrotic, but if we consider this as two disorders, we will treat those patients as IPF and treat them as COPD as well, okay? But we have what is called sub-analysis on those population or some of those population patients in the INPULSIS trial, and showing that the effect of or the impact of presence of emphysema in the effect of the nintedanib. So starting nintedanib in those patients with the no emphysema from the beginning has the same effect if we started on those patients with the emphysema at the beginning. So we believe that we need to start emphysema nintedanib in those patients. Right. Back to our patients. Okay, we started nintedanib for these patients. Unfortunately, the patient came back again to my clinic and say, I hate these medications. It's causing frequent diarrhea. I cannot stay in my room just for 2 hours. So the patient complaining of frequent diarrhea, but has no vomiting or weight loss, no constitutional symptoms, and lab showing there is no signs of infection, normal CBC, renal profile, and liver profile. So what should we do for these patients? I mean, this is the real scenario. This is a side effect of the medications. So what's the manufacturer said about this side effect? They said that 95% of the patients, they have mild to moderate diarrhea in intensity, but only 5% of all patients discontinue the treatment. And the majority of treatment, usually the diarrhea occurred in the first 3 months. What should we do? Before starting the treatment, we have to educate our patients about this complication because it is not a simple complication. Because the patient sometimes discontinue the treatment because of this. So we don't want to do, we don't want to have interruptions in the treatment. This is why we have to educate the patient before starting the treatment. And this is a message, very important message to all pulmonologists, for us as well, and for the family physician and general practitioner. And we have to tell the patient there is a possibility of diarrhea, nausea, and vomiting. And they have to modify their diet as well, that any factor that increase the diarrhea should avoided or discontinued. The other things, what should we do? We have to ask the patient to be hydrated during the diarrhea, and the patient needs admission, we will admit the patient. If the patient needs anti-diarrhea medication, we will consider it, and also antiemetic medication. Sometimes the nausea vomiting reduced by giving the patient medication in between the meals or during taking the meals. If the patient couldn't tolerate it, we can reduce the dose from 150 to 100. But if still continuous, at that time we have to consider discontinuation and shifting the patient to the other medications. Okay, good. The good things for this patient, I mean, we managed his diarrhea and he is satisfied, but he came back again after 3 months. I think this time he complained of non-specific upper abdominal pain and he's very upset. Okay, you give me a medication that's causing a lot of side effects for me. So one of the fault that we did, maybe we didn't educate the patient that these are the side effects, and we have to do this in all visits and the time of initiating the treatment. The patient complained of non-specific abdominal pain, no jaundice, no change in the bowel habit. What should we do now? So, LFTs. Okay, we have to do LFTs. Why? So this is by manufacturers that we have to do a baseline LFTs repeated every month for 3 months, then repeated every 3 months. So to detect any abnormality in the BFT, because this is a known side effect of the medications. We have to educate the patient if he has any pain, jaundice, or dark or brown urine, you have to seek medical advice. So what should we do if we have increasing the liver enzyme? It depends on the level of the increasing liver enzyme. If the patient, if the ALT or AST up to triple to the fifth of 5 times upper limit of normal, no sign, we can reduce the dose or do interruptions. Or if the patient has more than 5 times, we have to discontinue the treatment. So unfortunately, we discontinued the treatment for this patient, and we shift the patient to pirfenidone. So the second things, or the important teaching point here, that we have another medication as well. In addition to the nintedanib, we have pirfenidone. So don't forget pirfenidone, or don't forget nintedanib if you start the patient on pirfenidone. And we can switch from this medication to another medication. And these are the common side effects for pirfenidone and nintedanib that we have to educate our patient about it. So initially, with the first visit, once we decide about the treatment, we have to make a mutual acceptable decision between us and the patient. We have to share the patient in our plan. So we have to discuss the efficacy and safety of the medications, about the FDA approval of both medications, what's the side effect of these both medications, about the symptoms and the management of comorbidities, and what's the expectation. This is the common slide that I put it in every presentation that I do. So sometimes, as a physician, we prefer to start nintedanib, and sometimes we prefer to start pirfenidone based on the basic of the patient. So some patient loves the suntan, So because pirfenidone causing complication or skin photosensitivity, we started nintedanib. Sometimes the patient say that I'm hating the diarrhea, I don't want diarrhea, so we'll start with the pirfenidone. And this is, I will conclude with this slide showing how it's important to manage the patient of IPF from all aspects. This is a holistic approach in the management of the patient with the IPF, because we don't want to say only management is antifibrotic. We have to manage other aspects, including the need of oxygen, including the symptom management, including the risk factors, including the most important things that usually we miss, the psychological aspect of the patients. And thank you.
Programs that we're carrying at the Ministry of Health. Now, going to Dr. Ghader Haley, she will be talking about very interesting topic on the multidisciplinary team management of IPF. Dr. Ghader is a teaching assistant, Internal Medicine Department, College of Medicine, Princess Noura bint Abdurrahman University at Riyadh, and she's a research collaborator in Pulmonary and Critical Care Department. Please welcome Dr. Ghader.
Hello, good afternoon, everyone. Thank you for having me and inviting me to this conference. Today I'm going to talk about the role of multidisciplinary team in the management of IPF, and thankfully my colleagues already laid the road for this discussion, and they did talk about some of the really critical points pertain to this. So if we want to think about the role of the multidisciplinary team, we can divide this and view it in two different aspects. The first one is the making of the diagnosis of interstitial lung disease through the multidisciplinary discussion, and we will talk about this more shortly. Then we have the aspect of providing care to the patient with interstitial lung disease as well. Okay. So in terms of the multidisciplinary discussion, this has been practiced for decades in experienced and tertiary centers, but it has been introduced or described initially in 2002. This has evolved over the years, and the aspects or the components of the multidisciplinary discussion has been defined better since then. So now it's the preferred diagnostic approach and the gold standard way to make the diagnosis of specific interstitial lung disease. The meeting where the team members will rely on really critical information from the clinical data and the investigative workup, and all of this in total will help to make the diagnosis, utilizing the clinical reasoning and the judgment of the members. Then the aim of the multidisciplinary discussion is to establish a working diagnosis, as this will be a very important thing to start management appropriately. So despite the updating the diagnostic guidelines, unfortunately we still have cases that will present in a classical or atypical way, and these guidelines are not fit to teach us how to deal with these cases. So the components and the models that this discussion can be conducted. First, the core members of the team should include a clinician or a physician, usually a pulmonologist or interstitial lung disease specialist, a radiologist, and a pathologist. It's preferred that these members should have a really good background in terms of interstitial lung disease and be comfortable with these cases. It also has been recommended to include a rheumatologist, especially if there is a suspicion for a rheumatological condition. Then these information, the clinical and demographic data, the high-resolution CT, BAL, and serology, pathology data should be integrated into the multidisciplinary discussion to have a more comprehensive diagnostic approach, as each of these information individually might not have a significant diagnostic value if used in isolation. There are different models that the discussion or the meeting can be run. Could be as a small group discussion. This is usually at one center level. It could be a larger group at multi-center level. But then we have the regional and the national committees that will provide more experienced members to help with the making of the diagnosis. So this is a decision-making process that can be followed to utilize the multidisciplinary team meetings. So to start with is to collect history and clinical examination findings, as my colleague introduced earlier, get the spirometry and the radiological, in addition to the serology information. And with all of that presented to the committee, then a confident diagnosis might be reached, and subsequently the specific management should be started. If that confident diagnosis is not reached, the committee might be able to provide more recommendation in terms of the investigations to be used for that, to make a diagnosis. This is a summary of all of the guidelines that commented and talked about the role of the multidisciplinary discussion. So the first one is the Canadian Thoracic Society in 2017, when they reviewed the fibrotic ILD. They recommended to include a respirologist, a radiologist, and pathologist to the meeting. And also they recommended to have a longitudinal follow-up in these meetings of the patients whenever there is an emerging new information. Then Fleischner Society. So their recommendation is to have a focused group to be discussed in the meeting. So if there is characteristic of the disease or suspicion of non-IBF diagnosis, then these are the ones to include and discuss through the meeting. They recommended to have clinician, radiologist, pathologist, and rheumatologist included. They also recommended to have in-person or telemedicine meetings. The recommendation in terms of the frequency of the meeting, they said once a week or a monthly meeting, and that really depends on the volume of the patients. The goal and the aim of this committee is to make diagnosis and talk about management recommendation, and as we said, to review if there is any progression of the disease. Then the conjoint societies that Dr. Al-Ghamdi talked about earlier in their statement 2018, they recommended to have pulmonologists, radiologists, and pathologists as well as members of the committee, and they deferred the meeting modality to the members. But this was a conditional recommendation because they did not have enough information to recommend it for every single case. Then the American College of Chest Physicians in 2021 for the hypersensitivity pneumonitis recommendation, they suggested also to have the multidisciplinary meeting or discussion, and they also suggested here to have a confidence in terms of the diagnosis articulated whenever that's discussed. Okay. So why do we have a multidisciplinary discussion to make the diagnosis? The advantage of that is there is a higher inter-observer agreement that was noted, and also there is a higher diagnostic confidence. And that was observed in a study led by Berg and colleagues, where they reviewed the histologist diagnosis before and after the meeting, and they found that there was a change from the histologist diagnosis in about 30% of the cases. Also, there was a change from probable to a confident diagnosis in about 17% of the cases. Another study looked at this, led by Dr. Joe, that observed a change in the ILD diagnosis made before the meeting in comparison to the diagnosis after the meeting in about 53% of the cases. So this is really a major and a significant finding, as it led to more confident diagnosis that will subsequently affect the management and the treatment of each case. In specific, or in particular, in terms of IBF and multidisciplinary discussion, as we remember, Flushner Society, they recommended not to include these cases. But there are studies to show that there is a benefit to include these cases. So Dee Sadler and colleagues, they reviewed the multiple MDDs discussion that included 938 patients, with 80% of them having a specific diagnosis following the MDD discussion. 183 patients with unclassifiable ILD before the meeting and the pre-MDD diagnosis was changed in 16% of them. In about 41 or 42% of the cases, the pre-MDD diagnosis changed after the discussion. And in about 79% of the cases, for those cases with no diagnosis made by the referring physician, the meeting or the committee was able to reach a diagnosis. So also they identified that better prognostic discrimination between IBF and other ILDs was easily achievable through the committee and the discussion. Another study led by Dr. Walsh also showed that the diagnosis of IBF was made with higher confidence after including these cases in a discussion. There are limitations in terms of the MDD or the multidisciplinary discussion. First one that I can think of is lack of experience. If we don't have members with enough exposure to interstitial lung disease cases, or if they are comfortable with a set cases or set part of the interstitial lung disease, that will lead to a non-specific diagnosis made. Then we have a bias. So if we have a non-standardized approach followed through the meeting, or if the recommended guidelines are not followed due to personal preferences, that will lead to an issue with the diagnosis reached. And also sometimes the diagnosis is left to the most experienced person in the group to be made, and that will make a subjective decision-making process in this case. Then we have the issue of having incorrect clinical information, especially if the direct clinician is not involved in the discussion, or if there is incomplete clinical information provided. So, how to overcome these issues? This is a recommendation by Dr. Zhu and colleague, where they recommended to have adequate caseload to be able to have more frequent meetings. So the recommendations are made on a timely manner. The other thing is to have, as we said, members including respirologists or pulmonologists, radiologists, and pathologists. The data presentation should be done by the physician who directly is caring for the patient. Then we have all of this information that we talked about in terms of the clinical, radiological, and pathological information presented. So all of this should make the decision made by the committee more reliable and accurate. I just wanted to review quickly the application of artificial intelligence in terms of multidisciplinary discussion. So this is a group in Switzerland who proposed this approach to have and help with the diagnosis and prognosis of interstitial lung disease. So they recommend us to start with the data acquisition, and that includes clinical, demographic, and laboratory and radiological data entered into and gathered and then entered into the machine learning. And to start with pattern detection, segmentation, and distribution, followed by pattern extraction and quantification, and then data analysis to help and guide with the diagnosis and prognosis. I don't think this is something that will replace the clinical judgment. I think this will be a good thing to include in terms of as a tool to help that committee, but should not be used in isolation. The other part of this presentation is to talk about the multidisciplinary team role in providing care and delivering treatment. So the things that we want to achieve with that is to have a comprehensive management, to provide disease-specific treatment, to ensure that we have symptoms-guided treatment and improve the quality of life. It will also facilitate communications and decision-making, and it will help to deliver patient and caregiver-centered approach. So the components of the multidisciplinary team in terms of care delivery should include a pulmonologist or ILD specialist, then a pharmacist or a nurse practitioner or physician assistant to help with the drug monitoring and to monitor for any adverse events, and also to have pulmonary rehabilitation, especially in advanced disease, as this will provide a physical therapist, respiratory therapist, and dietitian who will help to optimize the overall care of the patient. Palliative care specialists, they do have a really important role, especially with symptoms management and with the discussion in terms of goals of life here. Psychiatry and psychological support. We know that patients with interstitial lung disease, they have higher prevalence in terms of depression and anxiety. Lung transplant specialists, if we have someone who is a lung transplant candidate with advanced disease, this should be introduced early through the disease if they are meeting the guidelines. This is a model or framework that was suggested by Dr. Mina Kalari and her group in terms of how to utilize this and provide care in a multidisciplinary approach. So they recommended to start first with the patient-centric care. So that will include the ILD specialist, so the physician, the respiratory therapist, the physical therapist, and nutritionist. And this will be focusing on the disease itself. Then they have the early integrated palliative approach. So here, when we talk about the symptoms and the advanced care planning and the education as well to be introduced into the care of the patient. Lastly is the patient care in the community itself, and that should be applied through the engagement of the community allied health and also close communication with the patient and the caregiver. When they applied this and used this approach, they found that patients were 24 times less likely to have respiratory-related ED visit and 2.3 times less likely to have respiratory-related hospitalization, which is a very significant numbers when we talk about interstitial lung disease, as we know that they end up with having a prolonged hospitalization with many complications. This is another approach suggested by Dr. Ferreira and her group, but this approach is focused on having a specialist or a specialized nurse in the IPF clinic to be able to address any emerging issues for these patients. So final remarks. The multidisciplinary team contribution will lead to a higher diagnostic accuracy. It will help to deliver optimized and tailored patient care and also to subsequently improve health-related outcomes. Thank you.
Thank you, Dr. Ghada, for beautifully illustrating the multidisciplinary management of patients, and this is exactly what we are currently doing and what we are practicing now when it comes to the management of IPF with our committee led by Dr. Abdullah Asiri. Please welcome back Dr. Mohammed Shabrawishi, and he will be talking about how to optimize IPF management in Saudi Arabia. We'll talk about Center of Excellence, subclinics, Sahha Virtual Hospital. Please welcome Dr. Mohammed.
Okay, so thank you again. So today, in this topic, I'm going to talk about optimization of IPF management in Saudi Arabia. So again, I have nothing to disclose in regard to this topic. And this is my outline. So this is just to remind you that the IPF prognosis is poor, as illustrated in the previous lecture. So unmet needs. So an initiative by 11 European patient advocacy group have identified key themes for unmet needs identified by the patients. These unmet needs are in relation to first the timely and accurate diagnosis, the access to different management forms, including supportive services and end-of-life care, the disease-related education and awareness, and the humanistic burden of ILD. So my talk will be focusing on tackling these unmet needs overall. So toward a better diagnosis, we know that the diagnosis and care pathway of patients with various forms of rare lung disease, including interstitial lung disease, mainly IPF, starts usually with the primary health care or the general practitioner. So these professionals stated at the front line need to know how to deal with these kind of comorbidities, since they are dealing with the most common diseases usually. So one of the gaps in dealing with such need is the lack of familiarity with IPF by the general practitioner. So these are the educational needs that needed to be delivered to the frontliners. So more training on rare disease in general, training in genomics and genetic counseling, update about the recent guidelines and management of such diseases, education also on how to communicate the diagnosis and treatment plan, information on the referral network and pathways existed for such disease, and the method to provide such educational needs could include rare disease program, medication curriculum, the post-grad courses, the online educational program, the on-site preceptorship, case-based session with experts, and also rare diseases websites. Another gap in dealing with the lack of in dealing with the diagnostic issues is the delay in diagnosis and or the misdiagnosis. Here in this diagram, we can see that the total delay can be divided into the patient delay and the healthcare delay. So the GP delay, the hospital delay, and the waiting delay from the specialized centers. The second picture showing also, the second diagram here showing that this significant delay is persisted among different countries with established ILD or IPF pathway. So the median diagnostic delay reaching up to 1.5 years or up to 2 years in some country. However, of note, in this same article that was published in the BMJ, the timing from imaging until the diagnosis was only 3 months. So that could suggest that maybe putting a certain fast track or pathway once patients have been diagnostic or have found to have some interstitial lung disease on imaging could have a fast track to be evaluated by the pulmonology as a solution to cut off this delay. The third thing is the accessibility to diagnostic testing and the importance of being referred to specialized clinic earlier. And here when we should mention the multidisciplinary discussion as mentioned in details in the previous lecture by Dr. Ghaden. So the role of MDD, as she mentioned, of course, can be precluded to identifying or reaching the diagnosis, evaluation the prognosis, and the crucial role in determining the choice of lung tissue sampling procedure and possibly genomic classification. And lastly, the impact of multidisciplinary discussion on the management plan. Furthermore, in this illustrated diagram of this study, so the multidisciplinary discussion have not only changed the initial diagnosis, but have an impact on the management lines, including the need for additional supportive services. Specialized clinic. So another aspect to meet the diagnostic, we know all is to refer the patient to specialized clinic. So I think here we need also as an improvement project in the kingdom to improve the patient of IPF to define the specialized clinic. So we found this definition of the specialized clinic by the European Reference Network, where they classify the clinic as specialized clinic if they have some competency requirement, including the in terms of minimum patient number and exposure, and procedure in terms of the clinical assessment tool that is available in the hospital or the center, and in terms of the human resource requirement. I don't think we have such definition, so establishment such definition could be a great aid in identifying the specialized clinic. What about the outcome from specialized clinic in compared to the non-specialized clinic? So in a large epidemiological study where around 30,000 patients with different ILD subtypes included, the patient with ILD initially managed in the subspecialized center have significant improved in survival. Not only this, but all-cause mortality or all-cause hospitalization have remarkably improved, especially in patients with idiopathic inflammatory pneumonitis, mainly IPF. Other outcomes in related to the timing of referral, or comparing the timing of referral to specialized clinic. So we can see in the graph on the right, the graph see the time from initial referral to the ILD clinic. The earlier the referral will result in a significant longer time to death or mortality. On the other hand, also in the graph on the left side, patients who have referred earlier to specialized clinic, they are more likely to have a preserved lung function than the patient whom referred late, especially more than 2 years. So these are, in summary, the advantages of early referral to specialized clinics. So there are the expertise and availability of multidisciplinary discussion with the required team members, the close and frequent follow-up for such patients. You have improved survival based on evidence. The possibility of being enrolled in clinical trials also in such center, and the availability of wide supportive services, as we will talk in a moment, that will help in managing these patients. In terms of management, here we should talk about the role of having a registry. So this is another area of improvement which has already been kicked off in the kingdom. led by our group. So registry, the added value of registry data will give us the benefit of having a long-term data for follow-up. We can focus on our population, so we have to study our patient mainly. It can be complementary to clinical trials, an important source for real-world data. So what are the questions and opportunities to be answered or found in registries is the difference between the countries and healthcare system, the insight on the disease progression, again, and real-world data about also the non-pharmacological treatment and management, and better characterization of acute exacerbation, and again, real-world experience in non-IPF fibrotic ILD. What are the challenges of having an IPF registry? So the comparison data of multiple registries, the standardization and harmonization of data, the methodological issue, the missing parameters, and so on, the selection bias, the administrative burden, and of course, the funding and cost. So another great service is already established by the Ministry of Health, is the Sahha Virtual Clinic, which is, or where specific specialties started to have referral to this hospital to provide the best diagnostic and management care. So these are the current specialties that included. I think ILD or IPF mainly could have a role in such a model of care opportunity. So in terms of monitoring IPF patients, of course, the disease is progressive, as mentioned earlier. Our objective is to increase the chance of detect any subtle changes, but clinically relevant deterioration. So this diagram is mainly focusing on what parameters are usually being followed and the frequency. No consensus data on exactly how frequent the patient should be seen. However, clinical assessment include the physical exam, the spirometry, the physiological test, spirometry, and 6-minute walk test. It is advisable by expert opinions to be done at every 3 to 4 months. In regard to the radiological assessment, it should be individualized based on the patient clinical status and risk for progression. When talking about monitoring patients with IPF, we should not only just focusing on the clinical and the respiratory status, we should also broaden the picture to look for the patient-reported outcomes. So the patient complaint, the symptoms, basically, the dyspnea, the cough, the fatigue, the deconditioning, the anxiety. And there are many tools that are meant to follow such symptoms. What about the telemedicine and virtual monitoring in IPF? So there is a growing evidence is establishing, mainly after the pandemic. So based on survey analysis, a total of 200 clinicians from different countries have been questions about the role of telemedicine in IPF patients. And these were the main purposes of having a patient being followed by virtual visits. It's to it can help in identify the disease progression, they monitor the quality of life, to monitor the use of medication, including the oxygen, to avoid the unnecessary person visit, and to provide early detection of an exacerbation. Furthermore, as a part of assessing the outcome from a telemedicine, overall in this study, it showed that around 60% of the patient being followed virtually have at least one medical decision taken. So there is a role, and still can be applied in IPF patients. This is an RCT that investigates also whether a home monitoring program improve the health-related quality of life and other outcomes in patients with interstitial lung disease. And we can see here that it did not show significant improvement in the measuring overall the health-related outcome. However, the psychological well-being of the patient has improved in such patient. So the hospitalization did not change. Also, the overall health-related quality measure did not change, but the general well-being of the patient in terms of psychosocial have been improved, and this could be explained due to the frequent monitoring of the patients. And the average number of medication adjusted per patient have also decreased. I think this is sequela of the close follow-up of the patients. What about the patient satisfaction from being monitored virtually? Overall, different studies have shown that the patient satisfaction is high on that manner. So, optimizing the quality of life of patients with IPF, as we mentioned, should be based or should focus on the symptom-centered approach, again, the dyspnea, the cough, and should focus on the applying the best supportive care, as I mentioned in the next slides. So dyspnea is common in patients with IPF, around 40% at the initial diagnosis, up to 70% after 5 years. Always we should rule out comorbidities causing shortness of breath in such patients, such as primary hypertension, cardiac diseases, muscle disorder, and sleep disorder. Oxygen has been suggested as a potential treatment for dyspnea exertion, especially in the hypoxemic patient. Evidence for benzodiazepines and opioids use still limited. Pulmonary rehabilitation is recommended in the treatment guidelines and showed also improvement in the exercise capacity, dyspnea scores, and the quality of life in patients with IPF. The second most common symptom is the cough, where almost 80% of patients with IPF experience some chronic cough, but the number of patients with severe disabling cough could be lower. So is associated with disease progression. We should exclude and treat the underlying comorbidities. Unfortunately, for the pharmacological treatment has limited evidence till now. What about the breathlessness and the ambulatory oxygen? So the primary goal of using supplemental oxygen in patients with IPF is to protect the organ function, which is the lung, which can potentially enhance the physical functioning and improve the quality of life and survival. So we have the famous MBOX trial, the first randomized control trial of its kind. It demonstrated that the patient with isolated exertional dyspnea, defined as desaturation less than 88 by the 6-minute walk test, whom used the ambulatory oxygen, the lightweight, the 2 kg, had an improvement in their symptoms with the usage of oxygen. However, another aspect of that is sometimes it might provide some anxiety to the patient when they are prescribed oxygen, and on the other hand, causing some limitation in their activities. So almost counseling with the patient is important. Pulmonary rehabilitation, by definition, it should include both the exercise and the educational component, and it is recommended by the international treatment guidelines. So we have a Cochrane review in 2021 that confirms that the short-term benefit of the pulmonary rehabilitation in terms of improving the quality of life score, improving the 6-minute walk test distance, and added a new information that this outcome is extended up to 6 to 12 months. It's not only shortened or up to 6 months as the previous studies showed. Also, improvement in dyspnea, improvement in depression score. There is an emergent evidence that they are associated with a survival. Lung transplant, as mentioned earlier, lung transplant evaluation should be conducted at early stage due to the progressive and the unpredictable nature of the disease to improve survival and quality with the transplantation. The early referral enable initiation of patient education in an earlier stage and allow time to address the other medical and psychosocial issues. What about the palliative care and end-of-life care? Despite being recognized as a necessity by the patient and the caregiver, the palliative care until now is still not really available in patients with pulmonary fibrosis, and far less developed in the area in ILD than in oncology, for example. So the main goal of palliative care for patients with ILD is to improve, again, and maintain the quality of life. And studies have shown that it's associated with an improvement in the healthcare quality of life, and it is associated with improved inpatient survival as illustrated in this study. So, disease-related education and awareness. Again, this is another big unmet needs declared by the patient and caregiver, not only the patient. So what are the educational needs need to be delivered for this patient? They need a disease-specific information on prognosis and treatment options, practical information. They need up-to-date information on the international levels. It should include the partners or the caregiver. How to improve on such matter is the verbal information from the healthcare provider, the high-quality, regularly updated website, the live educational survey, patient support groups could add again to such manner. So, in summary, taking care or managing an IPF patient is a holistic approach, as mentioned in previous lectures, and should target all of these aspects mentioned again. So with this, I conclude my talk.
Thank you, Dr. Mohammed, for capturing the unmet needs. It is very important and direct messages on what do we need to work now. Finally, please welcome again Dr. Mohammed Al-Ghamdi, who will be talking about IPF local evidence generation in Saudi Arabia. I can't highlight how much important is that we are focusing on real-world evidence generation in our country. Please welcome Dr. Al-Ghamdi.
يعطيكم العافية جميعا, and I'm happy to be here again. We have finally had our first IPF-related database. It's fresh, it's recent, it just got developed, and in our mind, we have these three main goals to look after: determining the IPF key characteristics, to assess the disease burden and the impact of the disease, both on the level of the patients, the society, and healthcare system, and to determine the IPF natural history and the outcome. Hopefully by analyzing the data and coming with answers, we will be able to inform the stakeholders, the managers basically, to improve the care and the services based on the result of the data that we collect, and this will ultimately lead to better outcomes. The data or the result of the studies that we will eventually conduct will hopefully inform the lung experts. It will enable us to form our own IPF-related guidelines, and that is also expected to be generated and distributed to all the primary care physicians and pulmonologists, and hopefully leads to early referral to ILD center, early commencement of treatment, and better outcomes. We have already talked about the importance of early referral. One of the studies that I have came across have shown that with every year of delay in referring patients with ILD, the mortality actually worsened. This is how our data that we are currently collecting looks like. It goes over multiple domains. Each of the domains will serve its own purpose. So we look into patient information. Here we have basically the age and the name and the MRN. We do have demographic data that we collect. It includes the patient age, the smoking history, the BMI, height and weight, and the likes. And then we have the visit date, which is a key component of the data. We have shown in the previous slide that multiple outcomes are related to the date of the visit, like time from the first visit to referral to the ILD, time from the first visit to the commencement of treatment, etc. The data would also include diagnosis, so that's include the date of the diagnosis and age of the diagnosis. We also collect data about the symptoms, mainly shortness of breath and cough, and the date of the first symptoms. Again, it will help us later on to conduct some studies and looking into some outcomes, including date from the first symptoms to the first visit at the primary clinic, and then from the first symptoms to the first visit with the pulmonologist or the expert, to be able to look and see whether there is delay in serving these patients versus not, like what happens in the previous studies that my colleagues have demonstrated. We are expecting that there is a huge delay in the kingdom, and I believe that it will be worse than what we have seen in US and United Kingdom in the previous lectures. We will go over we collect also the risk factors. Basically, the gastroesophageal reflux disease, smoking, family history, etc. We collect data about the comorbidities. We know that IBF patients may concurrently have comorbidities from the get-go, from the first visit, and they may also develop it over the time. So extreme surveillance and meticulous care is required during the first visit and later. Physical examination is also recorded. Lab tests are also recorded, including the connective tissue disease lab work. We document the CT pattern and the date of the CT, and the physiologic tests that are being conducted are also collected, especially the FVC, the DLCO, and the 6-minute walk test. The main procedures that we document are the bronchoalveolar lavage and the lung biopsy. The histological pattern is also recorded if biopsy is done. We define the disease stage as illustrated in the previous lectures using GAP index. It's a very straightforward score that only includes gender, age, and physiologic test. We document IBF management, both pharmacological and non-pharmacological. This will be a very important piece of data later on. It will help us to see what are the areas or the centers that have the non-pharmacological option of treatment, like pulmonary rehab, palliative care, education and multidisciplinary discussion, and what centers are lacking those and how we can optimize the services. It will also inform us about what centers have both medication, nintedanib and benfenidone, available, and what centers are lacking these medications. We'll also look into the IBF outcomes, the main outcomes that usually get published in the other registries, mainly the comorbidities like PE and lung cancer and pulmonary hypertension, hospitalization, whether it is IBF related or non-IBF related, and death. Just to give you an example on the importance of having our own ILD or IBF database, this is the Canadian Registry for Pulmonary Fibrosis. For short, they call it CARE-PF. It was initiated by Dr. Christopher Risen in 2015, and they published the protocol of the database. They described the organization of their database, and they also described the data that they are going to document and follow. And after 7 years of collecting the data, it took them 7 years to collect 1,300 patients. And I was lucky to be around doing my fellowship in the field of interstitial lung disease. So we came with the first paper out of, or the second paper to be more exact, the second paper out of the registry. It was published in 2019, and we described the overall cohort in this database. So if you look at the left side of the bar graph, this is a representation of the common disorders among the overall cohort. And to the right side, it's the most common disorder in each participating sites. They had 6 sites participating to their registry. Not all the provinces of Canada were involved. And to my knowledge, there are still 6 centers to date. So, يا شباب لو سمحتوا بس الصوت. So, in terms of the overall cohort, the most common disorders, representing 80% of the diagnoses, were idiopathic pulmonary fibrosis, connective tissue disease ILD, and unclassifiable ILD. The remainder were in decreasing order: hypersensitivity pneumonitis, then sarcoidosis, then the others. We also described the baseline characteristics of the cohort. The median age was 65. 50% of the patients were male, and 60% of the patients were smoker or previous smoker, either current or previous smoker. The patients were slightly overweight, and there was a mild reduction on average on the forced vital capacity and moderate reduction in DLCO. And the surgical lung biopsy was done in 20% of the patient, and oxygen use was required in 20% of the cohort. When we look at the comorbidities, and as we demonstrated in the previous lectures, they are common among the patients with ILD. This is the Charlson Comorbidity Index, which is a score that asks the patient about 18 different comorbidities, includes things like liver failure, renal failure, hematological malignancies, and other ones. A score of 0 indicates that there are no comorbidities, and as you can see in the bar graph, only 10% of the patient had no comorbidities, and the remainder of the 90% of the patients with IPF had actually 1 or more comorbidities. This is the first paper that comes out of the registry. We looked at the cost of workplace productivity loss in patients with ILD, and we published it in the CHEST journal, and we found a surprising result. This was the first study to look into productivity loss in ILD patients. Among the patients who are less than 70 years of age, so working age in Canada, only 30% of the patients were actually employed, and 70% they lost their job or they cannot maintain their jobs because of the significant impact of the disease that is inflicted upon them. We found that 55% of the patients either reporting presentism or absentism, and presentism basically means that you are at work, present, but you are not functioning very well, right? The average hour lost for productivity per week was 8 hours per patient, and the annual cost of productivity loss was 12,000 Canadian dollar per year per patient. And when you look at the societal or the society impact of that on the country itself, it's a huge burden. To the left side of the diagram, this is a box plot. We looked at the effect of the disease on workplace productivity, and we found it to be similar between male and female, and between patients with IPF and non-IPF ILD. So the impact of ILD is similar between IPF and non-IPF, female and male. It doesn't make a difference. We found significant correlation between cough and dyspnea and the productivity loss. So the worse your cough is, the worse or the higher number of productivity loss you will have. The more your dyspnea, or the higher the dyspnea severity, the more you're going to lose at work in terms of productivity hours. And this is why it is very important to have a comprehensive approach when treating these patients and involve the palliative care early on, as Dr. Shabrawishi have mentioned. Dyspnea management and cough management are vital for these patients. We did a similar paper investigating the same outcomes, but among patients with connective tissue disease, ILD, and we found that all the productivity loss outcomes are very similar between connective tissue disease, ILD, and non-connective tissue disease, ILD. So just having an ILD by itself is a problem. It doesn't make a difference if you are male or female, if you have IBF or non-IBF, CTD or not CTD. The effect or the detrimental effect of the disease is there. So I just want to use the last 4 minutes to describe the ILD Center at Cluster 2 in Riyadh. This is the MOH first and currently the sole multidisciplinary program. We are serving the whole kingdom and receiving patients from all the regions and the cities. And we are designed as an inpatient, outpatient, and consultation service. Our objectives are comprehensive patient care, timely diagnosis, patient education, survival improvement, and later on ILD-related researches, inshallah. This is the timeline of our center. We started the center as a clinic at the beginning. It was in January 2019. The following month, in February 2019, we established our ILD MDD team that consisted of multiple pulmonologists, 1 ILD physician. Now we have become 2, and 2 thoracic radiologists and one lung pathologist. In fact, we are 3 now. Dr. Agada have joined our ILD as an external physician. In December 2021, we have become an ILD clinical program, meaning that we are under direct supervision and leadership from the higher admin, and we were given KPIs to meet. In 2013, in July, we have established the ILD service line to describe what we are going to deal with, or how to deal with the referral from outside versus the referral from the cluster itself. And in July this year, we have become an ILD center after meeting all the KPIs that we were asked to follow. During this time, from 2019 to 2024, we have provided both pirfenidone and nintedanib as formulary in our pharmacy. So both agents are available in the 2 formats, dose 100 and dose 150 for nintedanib, and dose 801 and dose 267 for pirfenidone. We also started a palliative care service for non-cancer patients, for ILD patients, and I think we are the first to provide it, at least to my knowledge. And we have also reactivated the pulmonary rehab. It was there, but was not active, at least for the ILD patient. It was mainly dedicated to the COPD patients, so we have it now running as an active program. And we have also started an educational component of our program, and we started to have our own educator. It is true that it has certain responsibilities that are not wide, but at least we have something running. So this is our data based on an interim analysis in 2022. In June, to be more specific, more than 2/3 of our patients come from outside Riyadh, if you look at the pie chart on the right side, and only 28% from inside Riyadh. And when you look at the pie graph on the left side, the cases that comes from outside Riyadh come from everywhere, all the regions and all the cities. This diagram helped us a lot in formulating our ILD educational round. It was an effort that was between us and between BI, and we have visited several cities and conducted educational and awareness campaign. We went to Abha virtually. Unfortunately, I wanted to go there physically, but we could not. We went to Hail physically, and we went to Al-Madina, Mecca, Jeddah multiple times, and we went to Al-Khobar also. and inshallah the rest of the cities will be visited in the near future. These are the most common diagnoses, and very similar to the Canadian cohort. The most common disorders are connective tissue disease, IBF, and unclassifiable ILD. This was in 2022, so you would see a higher percentage for post-COVID, so it's 5%, but now they have become diluted, and they are definitely less than 1% if we do reanalysis of the same data. In 2022, we reached 266 patients. In 2023, mid-year, 338 patients, and now we have exceeded 400 dedicated ILD patients. We have confirmed the ILD diagnosis in 89% of our patients, and we were able to exclude 11% of the cases as not ILD, and that's based on a referral from a pulmonologist. And I think that's a good number, to be able to exclude 11% of the referral from pulmonologist as non-ILD. It's a good number. It makes a difference to the patient life and prognosis too. We did MDD for more than 80% of the cases to make the diagnosis, and that's satisfying the standard, the global standard. 50% of the patients were male. Age was 60, so just 5 years younger than the Canadian cohort. 2/3 of the patients are on ILD medication, whether they are antifibrotic, anti-inflammatory, or both. And unfortunately, 40% of the patients are already on oxygen. This is a sign that the referral is being made lately. So these patients are not being referred early on. 40% is double the percentage of patients on oxygen among the Canadian cohort. 11% of the patients have already been referred to the transplant center. It used to be King Faisal Specialty Hospital alone. Nowadays we have the National Guard Hospital. They started their service a year ago, and they are doing very well right now. They see the patients within very short time, and they are providing an excellent care. We have transplanted so far 4 cases, and alhamdulillah, all of them are still around. These are the KPIs that we have met. We don't need to go over them, and thank you very much.
Thank you, Dr. Mohammed. Now we will reach to the last presentation by Dr. Hajar Al-Dahim. She is advisor to the Assistant Deputy Minister of Therapeutic Suppurative Service in the Ministry of Health. Dr. Hajar, she is Director of Drug Policy and Regulation Division. She was appointed as the head of National Drug Information Center at the Minister of Health in 2015 and established more than 50 centers across the kingdom. Dr. Hajar is responsible for MOH formulary management and was recently appointed as a Drug Policy and Regulation Manager. She is a board member of a pharmacy professional society under the Saudi Commission for a Health Society, and also she is a board member of the Saudi Clinical Pharmacy Society. Dr. Hajar will talk about the IBF registry.
يعطيك العافية دكتور عبد الله. And I know we are coming to the end, so I will be very short and precise. And I'm going to add really an important messages that I've been hearing throughout the day. So first of all, this is my conflict of interest, so I have no real or potential conflict of interest related to the subject matter of this presentation. So I usually and always like to start on the Vision 2030 when it comes to Saudi Arabia. So we know that it is mainly 3 pillars: thriving economy, ambitious nations, and vibrant society. And this is where we were talking about the increase life expectancy of Saudis to be more than 80 years old. And when it comes to really the transformation in healthcare, again, we have three strategic objectives: ease access to healthcare services, improve the quality and efficiency, promote prevention against healthcare or health risks. And this is what our KPIs and objectives when it comes to healthcare. Again, why we are implementing these real-world, let's say, the value-based healthcare when it comes to certain management. And I've been hearing today a lot about patient care, patient follow-up, patient outcomes, improve life expectancy, improve patients' health outcomes. And this is what everyone, I've been listening throughout the presentations when it comes to patients' care. And we know that we are now considered in the Ministry of Health leading an initiative when it comes to rare disease, and IPF is being designed or defined as rare disease somehow based on the numbers of patients. And we've listened a lot on the delayed of diagnosis, number of centers that have been managing IPF, and the late presentations of these patients. So these are all pillars that we need to focus when it comes to the management of such diseases. And we know that these medications are coming, and the pipeline of these medications are coming, and they're not coming cheap. They are very high in price tag, so we need to make sure that we have the right access of these medications, because we all suffer from the budget constraints, and it's not only IPF that we are dealing with. And then, as I mentioned, it is one of the KPIs is to monitor and see certain outcomes of patients, so requirement of health outcomes, and then the utilization, as we are in the digital era, so we need to really utilize these digital data and keep it to our utilization. So I will be focused on what we have done when it comes to the managed entry agreements or the value-based healthcare when it comes to certain medications that has been introduced. And this is what we've done with the BI when we have discussed their medication, the management of IPF. So we have three components: clinical, financial, and service, and this has been all ticked by BI. When it comes to clinical, we have assigned on certain clinical outcome to look at and follow up the patients within at least a year, 12 months, is the percentage of FVC reduction. And then when it comes to financial, so either they have provided with number of FOCs as initiation or as a discount directly through NIPCO within their prices, and services with the development of the registry and certain activities within the registry itself. And we have as well developed the first and only in the region when it comes to the policy of managed entry agreements. So I highlighted different responsibilities and stakeholders who are involved in such managements. Alhamdulillah, we have قبل 5 سنوات احنا ما كنا في هذه البيكتشر. السعودية ما كانت هنا. Lastly, after 5 years, we have now in the 5th place after Australia in concluding or implementing managed entry agreements or value-based healthcare in the country. We all know and understand, and this is what we are seeing currently in our committee when we review these cases of IPF. So we make sure that the patient is being looked at or managed by consultants. We make sure that different diagnoses, different follow-ups and labs and imaging is being there. So, and the treating physician is as well being involved in the discussion when it comes to the management of these cases. So all of this is being ticked as well when we are reviewing these cases, especially when it comes to IPF. This is just a screenshot. I just wanted you to understand how we do that. So we do have a medical lead assigned by His Excellency in different disease areas. And then we created our scientific committee from different sectors and different regions in order to be close to multiple regions, not only Riyadh, but we need to make sure that we are close to multiple regions. We need to listen to them, know what is missing. So this is very important. And then we meet in order to have a setup of the what do we need to look at in building these registries, what data that we need to look at. And then we go in a registry deployment on a certain, let's say, piloting in certain centers, and then we expand. And we make sure on the registry governance and the quality check of these data in order to make sure that these data is really representative, and this is what the actual data of those patients, because we are reflecting on these outcomes based on these baselines. And then, hopefully, we publish each year after different registries data reports that we are generating, and inshallah you will be seeing these in the coming next year, inshallah, or late this year. I will not look deeply on that. I just want you to, sorry. This is just the timeline of starting IPF in the Ministry of Health. When did we evaluate the management of IPF? When did we include nintedanib into the formulary? And when we created the steering committee and we kick off the first meeting and introducing the first patient into the registry and follow up those patients. And IPF, or pulmonary that, it is a very unique committee because we involve the direct patient consultant or the patient treating physician into the committee in discussing the imaging, in discussing CTs, in how is the patient presenting and what is the, let's say, the needed outcome, just to make sure that we are understanding what are we looking out for those patients' outcome in managing IPF. So this is where are we at. So now we've reached to 40 cases, and we are doing this every week or every 2 weeks, making sure that all data and all required information is there before the committee is meeting and discussing these cases. By the end, I just want to highlight multiple key messages that has been talked today is the collaboration between different, let's say, hospitals, institutions, when it comes to the management of IPF. The early diagnosis is very important and it's crucial for patient to be, let's say, managed and have a better outcome. As we said that I think it's 3 to 5 years life expectancy after patients being diagnosed with this disease. Why? Because again, the late diagnosis of this disease to the patients, to the healthcare. Third thing is, I think we've talked about the guidelines and what's the adherence of the guidelines. I'm not sure if there is any local guidelines, but I've been listening to multiple guidelines, and this is what we are following up. And lastly, as one task that we are going to do, inshallah, after this meeting is we're going to have or publish the IPF burden of disease in Saudi Arabia, and they are all welcome to be a co-author in this project. By this, I end my talk. Thank you very much. I will just request for the speakers, because we'll have a small session of Q&A just before we close. Thank you. Thank you very much. I will be stating the question as we've got them, and please, if you have anyone from the audience have a question, please just let us know. Allah يعطيكم العافية جميعا. Great presentations. And the first question goes to Dr. Al-Ghamdi on regard to the lung transplantation. What is the percentage of lung affected by IPF which is related or which indicated to be a lung transplant?
Yeah. So among the idiopathic pulmonary fibrosis, we'll go over the criteria for referral and the criteria for listing, as they are more important than the percentage of the patient who ultimately needs lung transplant. Such data will be available more with the National Guard Hospital lung transplant physicians and the physicians at the King Faisal Specialty Hospital. I wish that Dr. Raid was still there, or here I mean. He would probably have the answer to that, because they receive patients from across the kingdom. So once the patient has idiopathic pulmonary fibrosis, it is appropriate to start the referring process. Due to the limited number of centers in the kingdom, we don't usually do that. So we usually refer the patient for lung transplantation when the actual transplantation is needed. So it is a bit late, but it's because of the limited number of centers that we have. It is not practical to refer all the patients with IPF. So we refer IPF patients once they need oxygen, once they have pulmonary hypertension, at least an echo, once their FVC is less than 50%, or the DLCO is less than 40%. And these are the main criteria to when to refer patients with IPF. IPF patients during follow-up will either die or they will require lung transplantation or continue to have the disease, IPF, and be ineligible for lung transplantation. So they will hit one of the three during the follow-up. Either they will meet or need lung transplant, they don't need a lung transplant, or they are not eligible for lung transplant. Category 3, they will die during the process. So yeah, it is a large proportion of patients who would require ultimately lung transplantation.
Thank you very much. Dr. Ghada, I'm biased in that presentation. So first of all, thank you very much for the beautiful presentation. Where do you see the presence of the pharmacists and clinical pharmacists in these multidisciplinary teams?
I think it's really important, especially in the beginning, just to make sure that we prescribe the medication appropriately, reviewing any adverse presence of any other comorbidities that will make adverse events more probable, and also in terms of the monitoring of the drug like LFTs and the other markers, and monitoring for adverse events after starting the medication.
Thank you very much. Dr. Mohammed Shabrawishi, is there any prophylactic measure for IPF?
So as we mentioned by all the speakers, I think the risk factor for having IPF is multiple, and unfortunately, not all of them can be controlled. However, one of the controlled is being, or one of the risk factors that can be tackled is the smoking, of course. So maybe smoking and its linkage to the IPF is already confirmed. However, the other risk factor, beside the family history, is in form of genetic and environmental exposure and so on. So until now, we don't have any guidelines recommending any prophylactic or even screening for idiopathic pulmonary fibrosis.
Thank you very much. Dr. Abdullah Asiri, is there any Saudi national guidelines for IPF?
For a time being, no. But Dr. Mohammed, he started to establish the registry for interstitial lung disease. and hopefully we will have, inshallah, in the near future, guidelines regarding the ILD in general and specifically IVF. Hopefully, near future.
Inshallah. Thank you very much. Because it's very important to standardize the care when it comes to different management from different sectors. Pushing the agenda of clinical trials, and as we've been seeing with multiple presentation today, multiple clinical trials being done in other countries of the world. This is a question for you all. Do you know any clinical trials that is being currently or is coming in the future very soon to Saudi Arabia, and have any of your centers been introduced to such clinical trials?
Yeah, so our center and the National Guard Hospital in Riyadh were approached to participate in the BI 101500 or something very close to that. It's a medicine that being investigated. It was a phase 3 trial, both for patients with IPF and patients with progressive pulmonary fibrosis. I'm not 100% certain if the National Guard Hospital have managed to recruit patients. For us at King Fahd Medical City, we were mainly focused on the IPF trial, and the study group have already completed the recruitment before we got into it.
BI, we are going to talk about this, inshallah, next week. Okay, any other comments from, in regards to clinical trials? Okay. Any questions from the audience, please? None, okay. Again, thank you very much for being here today with us. And inshallah, this will be an annual thing. And as I mentioned, we are going to do the burden of IBD in the Kingdom of Saudi Arabia, and you are all welcome to participate in that. Thank you very much.